So every day on rounds, right, you got to talk about the acute things you're treating, but you also got to talk about in rounds, what things are we going to do today to ensure this patient in 6 months is going to be able to put that bag in the overhead, is going to be able to walk down the street with the people they love or hold their grandchildren ever again. And those things have to start when they're ICU. They have to start in the post-ICU period. They have to start when they're on the floor. And how are we going to coach people at home? We've gotten them into this position. Now, how are we going to give them their lives back? And that should be part of rounds every day.
Welcome to Critical Care Time, the podcast for everyone who cares for people with critical illness. I'm your host, Dr. Nick Mark.
And I'm Cyrus Nick. On this week, we are very excited to talk about a topic in critical care medicine, really a topic in medicine that affects all of our patients, nutrition, and particularly nutrition in the critically ill.
Yeah, we are very fortunate to be joined by an expert to guide us, Dr. Paul Wischmeyer. Dr. Wischmeyer is an anesthesiologist and intensivist at Duke University. He's an expert in nutrition and the interplay of nutrition and exercise in critical illness. He's a prolific researcher. He's got hundreds of peer-reviewed publications, numerous awards. And then finally, as someone who's undergone more than 24 surgeries himself since childhood, he brings a uniquely personal perspective to the ICU and operating room, having experienced both as a patient. He's also very active on social media. Highly recommend you follow him on X at Paul_Wischmeyer, Wischmeyer. Paul, thank you so much for joining us. Welcome to Critical Care Time.
It's wonderful to be here and really great to have a chance to chat with both of you and to share some of the new data that really, I think, has changed the field of critical care nutrition and the field of nutrition really in general. So it's just a joy to be here. Thanks.
Thanks for joining us. Yeah, as we were saying before we hit record, this is a topic that we don't get nearly enough education in, and myths and misperceptions and 20-year-old studies tend to be perpetuated to the present. So I'm really excited to talk about some of the things that are cutting edge in nutrition in the ICU and to debunk some of these myths that just refuse to die.
Definitely. And I think, like we were saying, it's not surprising these are things we just don't learn all that well, given that 75% of medical schools don't teach any clinical nutrition at all, which of course leads those of us that are young physicians to think either A, it's not important, or B, there isn't much to learn. And I think that's the real crime almost of the whole process is something that is so fundamental to all of our health is just not something that we get training in. And I think, all of us have the chance to change that and to learn from podcasts like this in a quick way to get up on the literature.
Paul, again, thrilled to have you on the show, and we definitely have a lot to get into, and we'll do that in a moment. But if memory serves, I think you are the first, certainly not the last, but the first anesthesia critical care doc we've had on the show. And so, I like to know a little bit about folks when I get to talk to them. So I am just curious, if you wouldn't mind, I know this is maybe a little out of left field, maybe telling us how you went from, OR anesthesia to actually, hey, you know what? I want to be an intensivist as well.
Yeah, for sure. It actually was an interesting route in as much as I think for me, and we'll get to my motivations to medicine later in our discussion, but when I was in medical school, I think in my third year of medical school, in my very first rotation in pediatrics, had a very intense experience with a young 6-week-old who had a pneumonia. And his name was Anthony, and he had a twin named Antony, and a mom that was unfortunately about 17 years old. I was at University of Chicago, and we had a lot of underserved people from the inner city. And unfortunately, the child that was not in the hospital at the time came into the emergency room, got an x-ray, but the x-rays got mixed up because there was only one letter difference in the name. And that child was sent home because they looked at the child that was in the hospital's recovering x-ray. And that child came back really shortly thereafter, the child that was at home, in septic shock, and it had a very significant infiltrate on the actual x-ray done in the ED. The child was sent to the pediatric ICU, where I went over with the mom and the sister, who was about 18 years old. And sadly, that child died within not an hour, which is, of course, the first death I'd ever experienced as a student. But B, the pediatric intensivist left the room and said, I've got another very sick child, so I'll come back and talk to you shortly about what happened. And so he left me in the room as about a second week, third year medical student with the mom and the sister, both of whom were 17 and 18 years old. And I think I felt like, for whatever reason, whatever I said to them in that 30-minute period, I felt like I did more for them in that 30-minute period than I'd ever done for anyone in my life. And that intense interaction and that ability to really be there when people needed you made me realize this is what I want to do the rest of my life. And I want to be a critical care physician. I thought I wanted to go through pediatrics to do that. And so I went to University of Colorado, where I discovered that I was too big, too loud, and too impulsive to be a very good pediatrician. I was not good at bike helmets and breastfeeding, which is much of what pediatrics is. And I called the dean of my medical school after they put me on probation for various reasons, after doing well in medical school, thinking I would be a good resident. And my dean said, Paul, when you love things, there's nobody better. But when you don't, it's easy to tell. And she's like, are you sure peds is the right path for you? And so on the advice of a woman named Madeline Kahana, who's a triple trained anesthesia and critical care person, who some of the listeners may know, she said, come back and do anesthesia. You're going to love it and you'll be good at it. And just trust me, I'd never done a rotation in it. So I came back to University of Chicago, did anesthesia, and all the things that maybe not a very good peds resident made me a very good anesthesia resident. We like people who think independently, are kind of impulsive, and can actually make a decision. And so my intent,
and
all through
being
anesthesia,
loud when you need to be is a very important anesthesia skill.
Yes,
it is. You got to be able to go toe to toe with the surgeons. And so ultimately, I always intended to do critical care, and I found anesthesia a great way to do it. I did 10 months of ICU when I was a resident. There were very few anesthesia residents back then, so I could make my own schedule and trade all my chronic pain away. And then ultimately, I within a few years of getting out, and I did cardiac and transplant anesthesia for a few years, but as soon as I got my K award and took over the nutrition service, which is one of the other roles I fill at Duke as well, is running the TPN and nutrition service, I said, I'm not doing an OR anymore. I'd never intended to keep doing the OR, and I was able to move entirely to critical care and the nutrition and research. And so It was an interesting circuitous route, but I really found the training procedurally and pharmacologically and physiologically a good training base for me in the ICU, especially the surgical trauma and burn world that I've worked in most of my life.
Man, I really feel like I got more bang for my buck with that question, Paul. Thank you for answering that. And take No, this is great. This is truly great. It's like
it's a great introduction.
So nice to get to know you on that level and have an appreciation for why you do what you do, and perhaps an understanding as to why you are so passionate about what you do, because it shows. I mean, it shows within minutes of meeting you. So thank you for that.
And a good thing for our listeners who are in training too, to just realize that there are many paths that lead to practicing in an ICU. There's no right path necessarily. There's many converging paths.
And personality really matters. I think I loved kids, but even in my letters from medical schools, the only thing I didn't honor was peds. And I had letters that said Paul's sometimes at odds with the peds residents because their personalities are so different. And the person I wanted to have a beer with after work were the OB-GYN folks and the surgery folks. And I think for the students listening, that matters. The people you jive with and are your people, that might be your specialty too. It's something to think about.
Good advice.
Absolutely good advice. I think, Paul, I would love to just chat with you about your musings on medical school, medical education, et cetera. I'm sure Nick would as well. Yeah. But I think this is probably a good time for us to go ahead and start moving into the meat and potatoes, no pun intended. And we'll go ahead and get started here.
So let's start off by just sort of setting the stage. Paul, in general, how good a job do we do with providing adequate nutrition to people with critical illness?
Be honest.
Poor job. Abysmal is the word that comes to mind. And unfortunately, the U.S. is always the worst. So some of the big critical care research groups, Darren Hyland's group and other groups I've worked with, we survey practice, and he surveys practice of hundreds of ICU patients, really thousands of ICU patients and hundreds of ICUs around the world. And they look at about a 12-day period where the dietitians enter the data. And basically what we found is in the US, for the first 12 days of ICU stay, we average less than 50% of our patients prescribed caloric needs. So imagine that you wrote for a gram of vancomycin and the nurse delivers 500 milligrams for 12 days, right? We'd all be fired. But it happens in nutrition every day. And of the patients on nutrition, these are patients on vents and ICUs, routine patients, 90% of US patients never get to above 80% of goal. And we average about 0.6 grams per kilo per day of protein, which is less than half to a third of our guideline requirements. So it's not surprising, the muscle mass wasting, the ICU acquired weakness, and all those other things, we're starving people actively. And it's pretty devastating because it isn't true in all the world. I mean, the other parts of the world aren't that much better, but if you're in Australia or the UK, they're more in the 60 and 70% range. So it is possible to do better. and their protein delivery is better than ours. And so we have a long way to go. And I think there's lots of reasons for that we can talk about, but it's pretty devastating. And we've tried to change it on the enteral nutrition side, at least for 20 years with a lot of challenges.
Paul, that is pretty abysmal. At least, the raw data that you presented is worrisome, but could you paint that picture for us with a little more detail? Maybe kind of tell us, why does nutrition matter in critical illness so much?
I think a lot of people push back and they say, oh, they're sick, they don't need nutrition.
Yeah, I think the unfortunate part is we have decades of data to show that if we can successfully deliver reasonable amounts of early enteral or early parenteral nutrition, our patients' survival is better, their length of stays are shorter, their time off the vent is better. And now, right, that we have that data, we're now moving into trials we can talk about that we're looking at quality of life data as well. And there's some neat data actually that's about to come out of a Canadian group that I've been helping doing some mentoring with, where even we may have the protein target you need to hit to improve physical function at hospital discharge. And it may not be what we think it is. It's interesting. But nonetheless, right, we have all this data to say that this improves outcome. And I think there have been questions about that. We don't have a lot of randomized controlled trial to support many things we do in the ICU. And so even though nutrition has a robust body of data, there isn't so much one study you can point to like there is, say, for tidal volumes that you're measuring or for transfusion targets, that people can say, oh yeah, that trial says I have to do this. And I think to the data that exists, it should be common sense. But I think because it's not focused on a medical school, it's not something we focus on in rounds necessarily, and we can't point to that one seminal trial. It just becomes an afterthought.
Paul, there's one thing that you said that kind of rung true with me, is kind of the evidence and the level of evidence that's out there and the number of RCTs or the lack thereof. In preparation for this, I was looking at the most recent Aspen guidelines and trying to refresh my memory on what should I be doing. And the two things that stuck out to me were how much of a conflict there was between what I've read elsewhere, what's in the guidelines, what I've been taught, and then frankly how many of those guideline points are like low level or very low level quality of evidence. And so then I'm left wondering, does it even matter what I do? I mean, if I'm trying to practice evidence-based medicine, where's the darn evidence?
Yeah, and I think more and more of that data is beginning to come from real-world evidence investigations of large quantity of patients. We've done some studies in the Premier database here at Duke, both in COVID and in non-COVID patients, where we might study, the Premier database is 10, 15 million patients, 900 hospitals. And so we're very curious about what happens in real world practice when people feed better or don't feed better, given the limitations of real world studies. And the data consistently shows in multiple tens of thousands of patients in real world practice, recent practice, that mortality, length of stay, time on ventilator, and costs are all less if early enteral nutrition within even 72 hours now, we're not even pushing for 24, even if you can hit the 72-hour mark, you're going to improve those outcomes in real practice, controlling for the various factors you can control within our observational data. And so I think these kinds of trials exist in fair numbers, and there are randomized trials that clearly show that early feeding clearly leads to reductions in mortality, reductions of time on the ventilator, versus other trials. But like we had one in COVID and in the Critical Care Explorations Journal recently, we've just had one in Clinical Nutrition Aspen. More and more of this kind of real world data is coming out, and we can get to some of the myths around feeding. And there's some big observational trials of 50,000 patients and other sizes that I think really point to what's happening in the real world. And I think that kind of data needs to be a bigger part of how we think about our practice.
That's a great point. Let's get into the why. So why do we do such a bad job providing adequate nutrition in the ICU? Why is the U.S. dead last in nourishing our critically ill patients?
And I think some of that goes back to what we mentioned before, right? 75% of U.S. medical schools don't teach any clinical nutrition. It is taught better in other countries. I think we like to focus on things we can measure. And I've said this for many years, and I think we are finally starting to personalize nutrition like we're personalizing other care, right? We wouldn't give a vasopressor without measuring a blood pressure with an A-line or even a cuff. We wouldn't have somebody on a ventilator without a SAT probe and a blood gas. And so I think the lack of data for both prescription and for outcome sorts of things has really limited us. Now, it was neat. I got to work with a group in Europe as part of a grant the European Nutrition Society gave us to work with industry to build a better metabolic cart. There is a new metabolic cart that measures very accurately in 5 minutes. You don't need a respiratory therapist to do it. You don't need to calibrate it for an hour. It measures in 10 minutes and gives you very robustly accurate energy expenditures. And we're using that more and more in research and clinical practice. And we're realizing the targets that our equations predict are right less than the flip of a coin of times. They're about a third times they're right. A third of the time they overfeed, which we know is bad and causes infections. And they're a third of the time low and cause mortality and complications. I think the most quoted trial recently in ICU medicine is this Pierre Singer trial where they looked at about 1,500 patients and they looked at percent of calories delivered over the first week or 10 days. And they found that the absolute best survival happened between 70 and 80% of metabolic cart predicted calories delivered over that first week to 7-8 days. And if you overfed, the mortality jumped way up. And if you underfed, the mortality jumped way up. And so I think this kind of data is telling us, just like we would with pressors or ventilators, we have to personalize nutrition. We just did a whole issue, actually. John Blue and Son had me do a whole issue in critical care. And we just published a paper in critical care on how to personalize the 10 best tips to personalize critical care nutrition. So I can share those links in the show notes.
Yeah, I think that's a great point that, things that you can't measure, it's really hard to optimize or even to really think about, and not being able to measure nutrition in our patients makes it just kind of out of sight, out of mind for many people.
Yeah. Such a good point, Paul, because I really, until now, I've thought about the metabolic cart as being something we use in like the burn ICU. I trained in a burn ICU for a period of my fellowship, and we use that pretty regularly. Outside of that, I don't have a lot of exposure to a metabolic cart, and yet we would never, titrate vasopressors without a blood pressure. We would never titrate a ventilator without an end-tidal CO2 or a SAT or anything like that. And yet we're okay with doing it with nutrition. And then the other thing I'm reminded too is as I was preparing for my critical care boards a couple years ago, I remember seeing a critical care question on nutrition. It was like the 1 out of 400 questions that was on nutrition, which I got wrong because I was like, oh, we need to be more aggressive with our feeding in this patient. And the answer was like, oh no, you've got 7 to 10 days and you're going to go super slow. And you're going to give them 10 cc's per, hour for the first day. So this combination of not having the tools that we need, and then this vast delta between what we know and what we think we know and what we completely have no idea about is just mind blowing.
The 1990s called. They want their question back. Yeah,
that's really
it's rough.
And somebody better send it now because it's still probably on the boards to this day.
It probably is. Yeah,
so.
People are still getting that question quote wrong and learning the wrong thing from it. Maybe we should keep it very high level for a second and just talk at a very high level. What are the options for providing nutrition, like broad categories, and how do we deliver it? And then we can get into the nitty gritty of it.
Sounds good. Yeah, I think the first tenet that people have to think about is one size nutrition fits all doesn't work. I think the question, Cyrus, you got in particular is a good one because what the data is showing is in that first week of ICU stay, and we've been able to prove this in some of our recent publications using the metabolic cart, both in COVID and non-COVID patients, your caloric need initially is not as high. And the idea that you could start at 25% of goal the first day, 50% the second, 75% the third is probably the best practice. We even see that in the energy expenditures we measure. We can have these really sick COVID patients, these really septic looking patients, and they'll read out at 700 kcals need in that first week. And so part of that is two things. One is, Mervyn Singer taught us, right, that we sort of have this mitochondrial dysfunction that kicks in. We're not so good at using substrate in those first few days that we're sick. That probably is true. The other thing is true is if you're reasonably well nourished and have some muscle mass, your body is brilliant at breaking down muscle to generate glucose and generate amino acids to run away from the tiger, to run away from the surgeon, to run away from the car that hit us to survive, right? We have this evolutionary process. But then we run out. And if you're malnourished, you run out faster. And so malnourished patients probably need to be ramped up a little quicker, but for sure in the well-nourished patients, it is smarter to start slow, even with protein. There's data from Arthur Van Zatten's group, and this is a brilliant paper that shows if you get less than 0.8 grams per kilo per day of protein for the first 2 days of ICU stay, your survival is better than if you got to 1.2 grams per kilo per day of protein. But then that relationship flips about day 3. And so what we should be doing is not only in our calories, but in our protein. Start slow, start at 0.8 grams per kilo, about 10 to 15 kcals per kilo that first 3 to 4 days. And then say day 3 or 4, we can escalate up towards goal. And the protein needs to jump then above to probably 1.2 to 1.5 in most patients. Really catabolic patients, maybe 2, and people on CRT and things. But the data would say, right, we should be ramping both protein and calories. And I can share the references for that as well, because I think that's an important paper. And it really showed us, right, this is not just let's throw the tube feeds on it, 60 cc's an hour and feed everybody the same. There needs to be this ramping process. And then metabolic cart that needs to be done about once a week, or if they have a change in condition, they get septic, they have a big operation, check again. Because we saw patients both with COVID and without COVID that on the 5th day would be 700 calories. On the 12th day would be 2,700 calories was their energy expenditure rest, right? That doesn't include any physical therapy or anything else. So I think that is the first tenet, right? That this is a ramp and this is something that needs to be measured, both protein and calories. And then your choices obviously are enteral or parenteral. I suppose oral, but even most of our patients are intubated early on. And the data now would say enteral and parenteral can be used interchangeably. And I think that gets to the master question, right, that we probably still see on boards is parenteral nutrition associated with infection? And the answer is a vehement no. It is no association of any kind.
Wait.
I know, I was waiting for the question.
I was under the impression that they actually put Candida in the TPN.
That's what everyone asks me every day. I know. I wish they'd stop doing that. We'd have such better outcomes. Brilliant question. I get that question multiple times a week on social media. And the data actually would say, right, there's 4 large randomized trials. So the calories trial, the Nutria 2 trial, the Heidegger early SPN trial, and the early PN trial from ANZIX. These trials are in New England Journal, Lancet, JAMA. And so these trials showed no effect of PN of any sort on any infection of any kind in very, very sick patients. And so, and in fact, as we were mentioning before, there's even now a paper in JAMA Surgery that shows that use of early parenteral nutrition in large major surgery patients reduces infectious risk in patients who get it by day 3 rather than waiting for day 7. And so I think the key phrase here is it's just as safe to put TPN through a central line as it is saline through a central line. So if your patient has a central line, there's no reason not to use PN if you can't get to goal on your tube feeds, or if you can't start them at all.
And I think it's worth emphasizing that a lot of the literature about this is older, and this was before we had modern bundles for placing lines sterilely, for cleaning lines, having all of the wipes and chlorhexidine protocols that we follow. Yeah. So a lot has changed with central lines, and TPN is no longer the candidemia risk that you learned on step 1 and step 2. I think that's a really crucial myth to debunk.
And the other big thing that changed, and Nick, I don't know how old you are, if you remember this, but when I was a resident, I'm going to say it's not that long ago, we didn't treat hyperglycemia till they were 300 or above. I had surgeons tell me, let it run 350. It's a great diuretic. I mean, we would shudder. I mean, that'd be like, oh, malpractice. What is this person doing? Yeah. Right? But it wasn't until Greet Vandenberg's 2001 paper, right? And I started my practice right before that we realized, geez, we can't let people run 300 before we treat them. I mean, people complain about Greet's paper. Oh, nice sugar debunked the things she said, but Greet's paper is the most cited paper in all of medicine ever. And it changed practice in every field. I say it's one of the 10 papers, 12 papers, everybody that goes to an ICU has to know in all of medicine, because it changed the world. And it changed TPN dramatically, right? You're refusing D20 or even higher concentrations of glucose, and you're not treating the hyperglycemia that may occur because of it. Yeah, you're going to get infections. So all those trials that showed infection risk were done before glucose control was a standard of care.
That's a great point.
And before we have modern lipids, we have fish oil and olive oil-based lipids now, which are totally different immune function effectors than the soy Big Mac and fries down the tube that we used to give, and still is what propofol is made of, by the way, which is a significant immunodepressant. It's a pro-inflammatory immunodepressant, natural killer cell, bleeding lipid. I wish they'd get propofol out of it as well, but at least we can get our TPN lipids now that have fish oil and olive oil. It's much safer.
As a quick side note, is there any reason why propofol has to be in that soy-based lipid?
No.
So they could just reformulate it and put it in something else?
and they're talking about it. They actually, about 8 or 10 years ago, there was a product about to come on the market called Aquafol, which was an aqueous propofol solution that had some excitement. I actually had some interaction with the people making. We were going to trial it, and then somehow it got pulled, and I don't really know why it got pulled, but it did. And so now the companies that make it are dabbling with the idea of putting it into one of these fish or olive oil based lipids. But it's a generic drug more or less now, and there's cost implications to that. And I think that's slowed it. Is just people don't want to pay more for it, and so. But that propofol is nasty. It does a lot of bad things. It's also mitochondrial toxin, by the way, for all of you who want to think about propofol as a nutritional poison. It is. It was never meant to be given more than just an induction in the OR. When it's infused more than 48 hours, it has significant mitochondrial toxicity, inhibits electron transport chain. It depletes zinc very rapidly, has propofol infusion syndrome. So I give lectures in Brussels about the evils of propofol all the time. And so I try to get
we've bashed on benzos on this podcast before, but we probably have not bashed on propofol enough. Those are some great points.
Leads to increases in ICU-acquired weakness in a Canadian journal of critical care paper as well. So there are data showing it increases ICU-acquired weakness, which is not surprising because it injures muscle.
All right. Well, ketamine for everyone.
Amen. Say it again.
I know we're going to move on, I think, to talking a little bit in terms of timing, but I wanted to ask you kind of foot stomp something or follow up on something that Nick said, rather. So we talked a little about enteral feeds, parenteral feeds. You can use them interchangeably. You can probably, I imagine you can even use them together if you need to.
Best in case, probably most people.
Now, are there certain situations, particularly certain disease states, like, I don't know, fever or traumatic patients, are those patients that we need to pay special attention to when it comes to caloric needs?
Yeah, so clearly some of those different conditions will markedly increase energy expenditure. So a fever, it's interesting, occasionally during COVID, when we were doing our COVID metabolic card studies back when we didn't know anything about the metabolic rate of COVID, sometimes they were febrile all day long. And so for us to get our measurements for our studies, we had to measure them febrile. And it massively, as you can guess, 100% increase in energy expenditure, sometimes more. And so that clearly is a challenge. And then the question is, do you need to replete that or not? And I think when it's persistent, like in COVID it was, you are wasting muscle very rapidly. And I think you do need to take some account of that if they're sustainably febrile. When I was a resident, we had a continuous metabolic cart on one of our HP ventilators we used to use in the burn unit. And that was brilliant, right? Because I got a 24-hour energy expenditure, not just a spot one. And we used to replete to that target. And then we have to add activity factors and stuff to that. But when you have that total energy expenditure, and there is, I think GE makes one, and there's a few others potentially available, but they're pretty limited. It's nice when you have that total data, but we rarely have that. And so there is some account you do need to take. And then the physical therapy the patient's seeing, right? Everybody should be walking. I don't if they're intubated or not, they should be moving and exercising and doing something in the bed. And so you have to account for that. And I'll get into sort of my last illness and how many calories I was getting based on the activity and the resting. And it was a TPN that I'd never written before. It was so big. And I probably will start writing them again now that I have this kind of data that I can measure. So I think my prayer is activity and rehab is going to lead to the increases in energy expenditure you need to write for. But there is great variability in sepsis up and down. And that's why measurement's so important. And trauma as well, burn injury, wounds lose a lot of protein. And so it makes it very hard to keep up with protein losses in that setting. So your big wounds, your neck fascia, things like that. And I think all those things need to be accounted for.
I think it's really helpful to remember that every degree of fever increases your oxygen consumption and therefore your caloric needs by like 10 to 15%. But the problem is that, that's only if we're able to measure the fever. And a lot of our patients are on CRRT or ECMO, where the circuit itself is preventing the temperature from increasing, even though the tissue metabolism has increased, which really just emphasizes your point about we need to be measuring metabolism, not try to estimate metabolism based on a forehead temperature.
Yeah. And I think finally we have this Q-Energy device, and I will disclose I have been part of the development of that device, and I do work with now Baxter, who markets it around the world because I'm so passionate about its importance, and I think it saved my life. Actually, I'll get to, But I think it's so critical that this kind of data is there because it comes back to it again. We're critical care doctors. We measure things, and that's why we're able to take such good care of patients. And there's no reason we shouldn't be measuring this too, because I can tell you the variability is enormous. Nobody can guess.
Yeah.
Even our best dietitians, right, who are very good, but the equations just are not that accurate. And our data with metabolic card in all different critical care states are showing that.
So Paul, let me hold your feet to the fire for a second here and ask you specifically. I think we've alluded to this a little bit, but when should I actually be starting these enteral feeds in my patient? When is it too early? When is it too late? How do I go about approaching the initiation of feeding?
Definitely. So I think the first key thing is the patient hemodynamically stable. And that doesn't mean are they off pressors. That doesn't mean are they, not in the ICU septic. That means is their lactate normal or falling to normal? Are their vasopressor doses stable? Are they fluid resuscitated? I still occasionally like the mixed venous. Is the mixed venous reasonable above 70, right? So I think assuming they're hemodynamically stable and all those parameters are met, enteral feed should be started immediately at a trophic rate, 10 or 15 an hour. So for instance, some of you may know that follow me on social media, Instagram or Twitter, my mom was in the ICU last weekend and was intubated and on, I believe, fed at 0.12 on Saturday morning. Today's Monday, Tuesday, right? The small regional ICU she was in Missouri actually was more than happy and actually excited before I even got to the room to start enteral feeds because her lactate was normal. Her pressor dose was, even though 0.12 sounds like a lot, it was mostly due to the propofol she was on, they felt, which I agreed. And so they started enteral feeds at 15 and went up to goal overnight. And she did wonderfully with that and was extubated the next day. And so I think
that was within 24 hours, within 24 hours.
12 hours. Yeah, it was within 12 hours
okay.
of her being intubated. She was still on pressors. It was above 0.1. And I think that absolutely, is critical. And I think that gets to one of the myths, Nick and Cyrus, both you were saying was all these myths that permeate critical care nutrition. One of them is, don't feed on pressors. And I think if the patient's resuscitated, there's a trial of 52,000 patients from a large Japanese database that show if you're fed within 48 hours, even on leave-fed doses up to 0.3, your mortality is substantially lower. Even the group in the 0.5 mics per kilo group showed no difference. And that group was small, so there's a limited sample.
And these are not small doses.
No. And I wouldn't have fed before this data up to 0.1 was kind of my limit before. But now seeing this data and thinking about the non-nutritional value of nutrition, I think these are the patients you want to trophically feed, not re-ramping to goal necessarily when they're on pressors above 0.1. But, I think there's a couple of key things. One is it preserves the microbiome, which we know is good for patients. It maintains gut permeability. It vagus nerve signals. So the protein and fat in the stomach lead to an anti-inflammatory systemic vagus nerve signal. And so that's really critical. And then for those of you who know Ed Deitch or some of the folks that used to do the lymph toxicity, the lymph from the gut immune system in the gut wall sees the lung first through the mesenteric duct, and that causes ARDS. And if you ligate the lymph duct of an animal that's in shock, they won't get ARDS. And if you don't, they do get ARDS. And so it prevents that lymph from getting toxic, we believe. So these are the non-nutritional values of nutrition. And I have a paper in critical care on the use of feeding and vasopressors that I can give you in the show notes that talks about these. So I think we should be feeding on vasopressors. It's one of the next large randomized clinical trials I would like to do. I'd like to randomize that group. I think there's enough data that would be a brilliant, large-scale, pragmatic clinical trial. But I think the data right now would support feeding that group, starting trophically. The data would say actually trophic-fed patients do better than full-fed patients when they're on pressors. Small trials.
So just to emphasize a couple of those points you just said there, Paul. So a little bit goes a long way. Trophic feeds are enough. And this is not something to wait on. This is not a day shift problem. This is not a Monday problem when the nutritionist comes in. This is if the person meets the criteria you outline, you should start them on some trophic feeds.
Yeah, they're resuscitated. And if they don't have, the other GI things that would keep you from feeding, bowel obstruction, fistula, leak, the things that bowel ischemia, the things that we prohibitively don't feed under, then I would start enteral feeds. If they do have those things, especially if they have any malnutrition, but even within the first 48 hours, we usually start some supplemental PN. And we start PN the same way we start EN. We start it trophically, right? It's like, woo, what is trophic PN? Why would you do that? But it's the same idea, right? The body's making glucose. We really want to get the protein in, but at a low dose. So we start at about 500 calories, about 0.8 grams per kilo, and we'll start PN that way and ramp it up the same way. PN and EN really are almost interchangeable, and they should be prescribed similarly in their delivery.
No, I just wanted to double click on that a little bit because I think logistically PN can be a little bit tricky, because unlike if I ask the nurse to give some trophic feeds, they just go into the room and they get some tube feeds and they hang it and boom. Parenteral nutrition is generally mixed in the pharmacy. There's usually a get the order in by this time so we can make it by this time. And it seems like with those sort of logistical delays built in, maybe in the patients who meet those criteria, people who have bowel obstruction or some other, clear contraindication to enteral nutrition, we should be thinking about PN sooner so that it actually happens much sooner.
Yeah, I think that's perfectly said. I think what we typically say is if we don't think they're going to get to some reasonable goal of 60 to 70% of EN by day 3, come day 3, day 2, even if they're malnourished, we start a low dose PN and then we ramp it up. So it's not the first day necessarily. There are occasion times we'll make exceptions for that in the patient we know who's got ischemic bowel. We're going to go days and days and days. So then we may as well start early. But I think if you've got a patient who sort of doesn't meet those exclusions, but you're just struggling to get your enteral nutrition going for one reason or another, or they're not going to be fed well because they have bowel obstruction, bowel ischemia, things like that. Yeah, we'll start at 48 or 72 hours. And the data would say if you can start around 72 hours, you're probably reducing infection, you're making a difference. And then as I mentioned before, we have a large Department of Defense trial starting called Home, where we're going to use metabolic cart to guide every facet of nutrition delivery. And we're going to start at about 48 hours in abdominal trauma patients for the military, because a lot of places are shifting away from pharmacy-made PN, like you said, it's a challenge, to premixed TPN. They're bags that can sit on a shelf. They're shelf-stable for 24 months. The nurse squeezes them together, the lipid, the protein, and the glucose. They shake it and they hang it. So it's like enteral feeds. It can even sit in the unit. And so from the military point of view, we're like, God, we can put the metabolic cart and all these things in the field. So they're interested from the Department of Defense point of view. But even in our practical ICU world, premix bags, which we do a lot of our trials with now, are really good options because they're almost like, pack or like, flip a switch and you're on it. It's just like enteral feeding. You squeeze the bag, pop it up, and you titrate the rate just like you would an enteral feed rate. And so I do think that's the future. The dietitians in the U.S., I always feel badly because they feel like, God, this is going to take our jobs away because that's a big part of what they do. There'll always be a role for them to do the precision TPN as well. But I think if we wanted to start something quickly, there's a role for this, and in the field perhaps, or in small hospitals that don't have pharmacies.
And arguably there'll be more patients receiving PN if the barrier to starting it is lower.
Our census has doubled since a lot of this data came out.
Man,
interesting.
So that's really fascinating. And one point of clarification. So I think the big takeaway for me is there is a difference when it comes to nutrition between you're on pressors at a stable dose and things seem to be getting better versus we're up titrating pressors. They're those both colloquially we'd say both patients are on pressors. They're sort of hemodynamically unstable, but there's varying degrees thereof. And so if you take that, in the context of nutrition, the patient that's on a relatively stable dose, that definitely would consider enteral nutrition and parenteral nutrition too, if indicated. Now, I guess my question is, if you do have someone who's a little bit more in flux from a hemodynamic standpoint, maybe they're not like approaching cardiac arrest, but you are titrating pressors a little bit more than
you've added a second pressor.
Sure.
Like they're not coming down.
Would that be someone for whom PN would be an option sooner, or do you have the same concerns about PN with a moving target, hemodynamically speaking, as with EN?
I would say the same concerns. And I think this is where now you go to our measures of resuscitation, right? What's the lactate doing, right? If you're adding a second pressor and the lactate's climbing, at the very least, I would pull down your EN to trophic. I might even stop it and hold it for a while because the body can't use it. The Nutria-2 trial showed, so the Nutria-2 trial was this fascinating trial, right, where they randomized people with septic shock whose average vasopressor dose was 0.5 mics per kilo per minute in Levophed. Because in France, I've noticed their trials. If you read French trials, they use more Levophed than we do. Their doses are outrageous. You'd be like,
Their approach to levothyroxine is like their approach to wine, just like
exactly.
vast
More is better.
More is better.
Really,
More is better.
I mean, you got to toss it back. So they have these huge doses, and they randomize people with very early EN or PN. And as some people know, the signal was the early EN group and that high dose pressure group had more bowel ischemia. There weren't a large N number of patients, but there was a statistical difference. There were definitely bowel ischemia patients that occurred in the intergroup that didn't occur in the parental group. But what I would say to your question is, if they're becoming unstable, or you're really ramping pressors, or their lactate is going up, or their mixed venous is going down below 70 and becoming really low, I would stop both. We hold PN when that happens. We hold EN when that happens. I think at most, if your lactate's still reasonably normal, but you're really feeling like you're starting to lose a little control and the pressures are going up, I would pull the feeding back to trophic. I think, you could even reduce the PN rate if you needed to, or stop it altogether. I think you really don't want to be feeding either IV or even intrally an unstable patient with a lactate that's climbing or with pressors that are escalating, mixed venous that is dropping. But the lactate and mixed venous, I think, really can be the guide, right? There's plenty of people we bump the pressors on, lactate's normal, we feel like they're still fully resuscitated. I think you're okay to keep feeding that patient. But boy, if you're losing control of your markers of resuscitation, both lactate and mixed venous, that's a patient you really don't want to be feeding.
That's a great point to emphasize.
Yep. Yeah. Thank you for hitting that hard.
Either way, you're going to cause all kinds of metabolic challenges to the patient. They can't deal with the amino acid load. They're going to start building up urea and other metabolites. We know liver blood flow when people are in shock like that hits the ground. So, maybe it's 20 or 30% of normal. And so they're not going to metabolize things properly. You're going to get a lot of toxic metabolite buildup. I think the redox trial was a trial Darren Highland and I did where we gave large doses of glutamine. And I wish we would have kept out the renal failure patients. We would have had a positive trial, but we didn't. We saw, and I did some metabolomics on that trial, we saw some unusual products of metabolism occur in these very sick patients who we gave these high doses of amino acid, especially when they had renal dysfunction and liver dysfunction, that would make me quiver to give large doses of protein. And there's even now protein trials. Some of the new effort protein trials showed that when someone's BUN doubles, you should pull the protein back down to a gram per kilo at most, probably, because they're starting to accumulate metabolites that the BUN's reflecting it, but it's not showing you all the things it doesn't measure. And so there's new data from Zut Pundicherry just published in the last few weeks from that trial that shows, when the BUN is really climbing, doubling or tripling, you need to pull the protein down because mortality goes up. And this goes back to what we saw in redox as well, right? All the excess mortality in redox, that glutamine trial we did, was in the renal failure patients we all thought they'd get CRT, but not everybody gets CRT early. And that was the group we saw it in. If you were on CRT and got glutamine, it halved your mortality because CRT wastes amino acids and pulls off about 30% of your amino acid production. So they need 2 grams per kilo. They probably ultimately will benefit from a trial of glutamine in that setting. But boy, if you're a renal failure without it and your BUN's climbing, even if it's only, say, 50 from 25, pull your protein back. And that's really new data. That's like weeks old data. And I think, but we all saw that coming because we'd seen the analysis at meetings.
I really want to get into the weeds and talk about specific amino acids like branch chain and glutamine and stuff. But before we go there, let's just talk about how we are delivering enteral nutrition, like oral versus nasal and gastric, duodenal versus jejunal. Like what type of tube in what person? What's your approach to that?
So when we do surveys, 95% of the world feeds the stomach. And I think ideally, physiologically, feeding the stomach is the way to go. That's how we do the majority of our feeding. I think clearly there are populations like our transplant surgeons, for instance, our lung and liver transplant folks really like the post-pyloric tubes. I think they worry about aspiration in the lungs, and in the liver transplant, they disturb the pylorus and the direction it takes. They're very hard to place post-pyloric feeding tubes, and I try a lot. And so they probably have more retention. But the data would say in the randomized trial that was done by Andrew Davies by the Australia ANZICS group, that there is no difference in post-pyloric versus feeding the stomach and aspiration pneumonia or other complications. So I don't think people should worry or be focused on achieving post-pyloric tube placements to wait to start feeding, because the data would not support that. I think there are patients that is a useful thing in. I think there are patients clearly that get gastroparesis. The new obesity drugs that lots and lots of people are taking to lose weight and to treat diabetes cause profound gastroparesis that can last for weeks. I've had patients in my ICU, a couple of them that were losing weight to have an operation, had the operation, had such profound gastroparesis and GI dysfunction, they aspirated in the tract. So these are drugs to be wary of, and they may be patients you want to try to get post-pyloric in if they've been on those drugs and you're noticing feeding intolerance, because the stomach may not work for a long time. But as a whole, feeding the stomach is the way to go. And I think that is a big limitation to people feeding well, because they have this in their head. A lot of hospitals, I got to get a tube past the pylorus. That is just not true. And that is not how most of the world practices, and the data doesn't support it. And so I think people should feel confident that they can feed the stomach in the majority of patients, and they'll do well. And I think that's really critical. And I think it gets to some of the other myths, right? The other patients I see people trying to throw post-pyloric tubes in are, say, like the prone patient, right? There's this myth that, especially in COVID, we prone a lot of people, oh, no, we can't feed the prone patient, they'll aspirate. Well, that's not true either. There's definitely trials that say you could feed the prone patient. You don't need to be post-pyloric to do it. The good thing about proning is, right, if they do bring up something they vomited out of their mouths, and it typically
right. If anything, you'd think the aspiration risk might be lower. Yeah.
Right.
And we put them a little bit of tilt, like 15 degrees, and the guidelines say this too, so that they have a little bit of tilt, not 30 degrees necessarily like you would on a sitting up patient, but we put them a little tilt too to prevent stuff from sort of passively moving up.
That myth has always struck me as funny, because it's like, even in like basic CPR first aid, it's like, if somebody's vomiting, what do? Do you keep them on their back? No, you roll them over, right? Like it seems like if it works in that setting, it should work in another.
For sure.
That's one of the most pervasive myths. Let's go through a couple of these other myths quickly, because I think there's a bunch of myth busting to do.
Absolutely.
Maybe my favorite myth to bust is gastric residuals. Do you want to tell us about those?
Yeah.
Well, we check them multiple times a day, every day, right?
So we know, at least in medical ICU patients to start with, there is no need, no reason, do not check gastric residuals. And that goes back to one of the other Nutria trials from Rainier and his group in France, where they looked at the incidence of aspiration pneumonias and other complications in patients who had gastric residuals checked versus those that didn't. And there was no difference, except for the people who had GRVs checked were fed really poorly. So basically, checking gastric residuals doesn't help your patient, other than it leads to them being starved. So it starves your patient, but it definitely doesn't protect your patient. Now, I will tell you, as a surgical and burn intensivist and trauma intensivist for a lot of my life, in the patient who's had GI surgery or in a burn patient, I do check them. Now, only meaningful cutoff is 500. I don't want to hear about the 200s. I don't want the nurses calling me for 350. I don't want people saying, oh my God, it was 0 before, we feed them 10 cc's an hour, now there's 350. The stomach makes 2 liters a day. It's not the tube feeds, right? I mean, but none of those numbers have been shown to be a risk to the patient. 500 is the cutoff. I do like them in the big abdominal surgery and burn patients, because they're a marker of dysfunction, like whether that's, a leak or sepsis or an abscess formation or other things. So I think in the surgical setting, an occasional check, once every 6 or 8 hours is useful. Usually the patient begins to show distension and other signs as well. But, in the burn world, for those of you that have done burns, the patient will get fed well until they get septic, and then they'll suddenly have residuals, and you can see it coming 2 days before they spike. And so it's a wonderful marker of sepsis in that population. But in the MICU, do not check them in the medical setting. I think in the abdominal surgery and the burn setting, it's probably worth it. But the 500, nothing less, needs to be the cutoff, because the data, there's multiple trials and meta-analyses that support that. So, but yes, that is a major cause of poor feeding. It takes an act of God to start tube feeds and the nurse going to lunch to stop them.
Let me ask you about another myth as we're kind of busting these myths. So, my patient who's on neuromuscular blockers, or maybe my patient who is also on, getting targeted temperature management for whatever reason. Are those folks that I should just not feed?
Yeah, I get that question a lot. I'll even have residents ask me, well, we've paralyzed their muscles, so their gut doesn't work. Well, we know that neuromuscular blockers do not affect smooth muscle, only skeletal muscle. The gut works just fine. I mean, one of the joys of anesthesia and surgery is we watch the surgeons operate on the bowel and hold it in their hands, and it peristalsis when we have the patient paralyzed. And that also shows you the surgeon doesn't cause ileus.
They don't shout at you, more paralytic.
Right. Make the bowel stop moving. It's annoying me. I can't sew to it. That just doesn't work, right?
That's like when the ortho docs are like, the muscles are twitching, we need more paralytic, and you're like, you have a tourniquet on. Like, how is it going to get there?
Some really, really great lessons to be learned in the operating room for sure. Yeah, I mean the craziest things, right? But I get that question a lot, believe it or not, right? Oh God, they're paralyzed. We can't feed them because the bowel's not going to move. Well, that is completely not true. We know again they don't affect the smooth muscle of the bowel. Then there's another data. There's another great publication from that same Japanese group that did the Presser paper. They did a same observational look at patients on neuromuscular blockers, and they had significantly better survival. They had significantly improved outcomes, and they didn't have any increase in pneumonias or other risks. So in a large multi-thousand patient observational study from that same Japanese group, they showed clear clinical benefits of feeding on neuromuscular blockade without any of the risks that one might imagine, including aspiration or other complications.
So not only is that myth not true, but in fact, the converse is true. When we're starting patients on neuromuscular blockers, that should almost be a checkpoint. Like, why are they not getting enteral nutrition?
Yeah, because you're increasing their mortality if you don't feed them. The data would clearly say. So I think, but yeah, that's a myth that's got to go. And also physiologically, it doesn't make any sense. So, but that's
Cyrus, you mentioned this. What about patients who are cooled, who are people on targeted temperature management?
We do feed them. You know, when you start to get into the pentabar coma people that are cooled and you're really doing serious head injury management, they will have a lot of gastroparesis and a lot of ileus problems. And so we often drop them to trophic. Not always. I mean, sometimes they tolerate, but you know, the pentabar coma thing and really deeply cooled can be a challenge, but we still always try.
And I would imagine that for the same reasons that fever increases your caloric needs, people who are cooled have decreased caloric needs.
Some decrease. Some decrease. To get to the other question that you might ask, do paralyzed patients have less caloric needs? They don't really. That was studied by Arthur Van Zandt in another paper where he compared patients before they went on cisatracurium and then after. The difference in metabolic need by metabolic cart's about 5%. So it's trivial. It has no relevance actually to caloric feeding. So, and we found that in our COVID studies too. A lot of our COVID patients ended up paralyzed. We did not see changes in their metabolic energy expenditures that were meaningful in any way. So,
well, that's
counterintuitive. That's very interesting.
It is. I wouldn't have thought it either. But now that I've seen the data, now that I've seen it in real life more than a few times, not much change at all. Right, the muscle remains active enough to need the caloric. It's muscle mass, and to some extent, we think that drives an immune function that drives energy expenditure. So
let me ask you, Paul. Let me ask you this question. So, in these cases, or in specific disease states, COPD, ARDS, liver disease, like in these cases where ideally we're feeding enterally and we're feeding to goal, but for whatever reason we can't. This person is they're cooled, or their residuals are 600-700 for whatever reason. Are you generally is that like a time that I should think, oh, maybe I need to supplement with TPN to actually get closer to goal?
Definitely okay. So, and I think to take them piece by piece, I think COPD is an interesting illness, right? And this is where the other features of a metabolic cart indirectometer can come into play, right? So you get another number besides the energy expenditure in the VO2 and VCO2 that you can calculate cardiac output by the Figg equation from. Again, that's kind of a nice piece of having an energy expenditure measure from a metabolic cart. But you also get the RQ. And the respiratory quotient tells us about substrate utilization, right? If it's below 0.7, if it's below 0.8, we kind of think you're breaking down muscle and probably you're underfed. Not always true. Really sick people are always kind of low on their RQs typically. But if you start getting above 1 or even to 1.2, that's a person who's generating a lot of CO2, and it's going to be really hard to wean from the vent. And I can think of more than a few patients, usually trach patients, that we are having trouble having them do trach color trials and getting off the vent. We'll get a metabolic cart in them, and they'll be 1.2 on their RQ, and we adjust their enteral feeding or their parenteral feeding to reduce the carbohydrate intake and take up maybe the fat intake, and they come right off the vent because they don't generate as much CO2, their hypercarbia is less, their drive to breathe is less, and they're able to wean from the ventilator. So metabolic cart and indirect calorimetry gives you another measure that can really help in COPD patients and other patients' respiratory failure that can help you wean them. And a lot of times you won't even think that that's something that's causing a complication for them, but the reality is their carbohydrate load is too great for their physiology, and they can't breathe the CO2 off effectively, and they can't get off the ventilator.
I've been surprised a number of times by that. It's interesting when you see how common that turns out to be. Maybe we should actually back up a little bit, because not all of our listeners are ICU. Some of our listeners are in the ED, hospitalist. Maybe we should just define what a metabolic cart is at kind of a high level.
Sure. Yeah, so an indirect calorimeter is a device that measures VO2 and VCO2 of exhaled gas. And so there's a number of ways you can do it. It's a device that now the new version of the device is about this big, and it sits on a cart. It weighs about 5 pounds, and it
Size of a
calibrates
bread box to people
5
listening.
minutes. Yeah. So and it measures VO2 and VCO2, and from those numbers, it can calculate energy expenditure at rest. Typically, is when we measure
How much
it.
CO2 are you making? How much energy are you consuming?
Yes, correct. And so that's a really brilliant part of it. It can be hooked to a ventilator. It can be done in a patient who's extubated with a hood. We put a big box over it, or you can be done with a mask. One of the limitations of the new devices, they average the output over about 30 seconds. So you have to have a constant oxygen source, either a direct hook to the ventilator or someone on room air. So these newer sort of highly accurate self-calibrating versions can't be used with people on oxygen. So if they're on nasal cannula or high flow, OptiFlow, you can't use them. There are some older devices and more advanced devices that do breath-to-breath analysis of VO2 and VCO2. They can be done with a patient on oxygen, and we have those devices too. They're mostly for research. Some hospitals still have devices like that, though. But the newer devices, the ones we're suggesting to people that are super accurate, and our dietitians pretty much run them, they intubated, non-intubated, but not people on oxygen. And so, but really easy to use otherwise.
And from the perspective of like the bedside nurse or the patient, like what is it like to do a metabolic cart on a patient? Like what does this look like?
So if they're intubated, typically we have our dietitians do it. They come in and they have the respiratory therapist do a quick, they put a little piece into the ventilator circuit that takes about 5 seconds. In COVID, we would wrap it in plastic, and we would do it inside of a saran wrap plastic because we didn't want to spread COVID all over the room. And you stick that piece in there, and then you hook up one other output to get the oxygen, the FiO2. And then the thing takes a few calibration breaths, and over about 10 or 15 minutes, it gives you a steady state energy expenditure that draws out on the screen. The respiratory therapist comes and pops the thing out and sticks the two back together. It takes about 5 seconds, and you're set. The newer devices can measure up to an FiO2 of 70%. I've measured people up to a PEEP of 16. The CRRT machine has no effect on the accuracy of that measurement. That's a myth that actually has been debunked from recent publications from Elizabeth Duvalley's group. There's a very minimal, maybe 20 or 30 calorie effect of the CO2 loss from the CRRT circuit. So there's no reason not to do one on CRRT. The really only contraindications are if you have a bronchopleural fistula or if you have an air leak from a chest tube, because then you don't have a closed circuit, or if you're an FiO2 greater than 70%, and then the accuracy of the measures become suspect. Other than that, there aren't a lot of limitations to their accuracy and to their usefulness. There used to be a lot of contraindications to it, but now that's really gotten better with the new devices. So we use them a lot.
So you can do it in people on high support. It's quick, it's easy, doesn't require the patient to be compliant with the test if they're on the ventilator. Doesn't disrupt the circuit very much, just one quick break. So I think the barrier to doing this test has gotten much lower over time. Much lower.
And then the extubated patient, right, you just come and put a hood over them, or you do the mask. Some people prefer the mask to the hood. You have them under there 15 minutes or so, and they're done. And it's a big box with some plastic, and it just measures them as they spontaneously respire. And that's pretty easy too. Awesome. So, and the nurses usually don't even have to be in the room. So usually the dietitians
barrier to entry is low, so that's good to know.
Low. Yes, very much
good to know.
All right, one more myth I really want to debunk. This is one that just really irks me. How long do we have to wait to use the PEG tube? Because often you hear very conflicting things from different services. If IR places it, it's one thing. If GI places it, it's another. If it's placed by the surgeons, it's still a third. What is the ground truth here?
I mean, the reality is you probably don't have to wait at all. Listen to your surgeons. I occasionally have surgeons say 24 hours. That's the longest I've ever had anybody have me wait at this point in sort of modern surgical intervention or GI intervention. But most of the time you could feed right away.
Yeah, and I think that the latest Aspen guidelines say 4 hours, which is kind of the classic compromise. Nobody gets what they want definition, but like it's short, which is the key thing.
Somewhere between 4 and 24 hours is probably a good number, but not more than 24 hours. There's no days and days or 48 hours or any kind of large amount of time that needs to be waited for. I think that is gone by the wayside. And I think this is not a bad time to mention, if you've got procedures that are going on in your patients that lead to breaks, volume-based feeding strategies are a really good strategy. The PEP-UP trial that Darren Highland did was a really good study that showed that he started patients at goal versus ramping them up. And it was just as safe and efficacious probably to start people at goal is what the data would say, and they got fed better. And so you can do a volume-based strategy. Say you want to deliver 1,000 cc's over 24 hours, right? If you have a 3-hour break, you just start the rate 3 times higher or maybe twice as high for a couple hours after that break. Let's say they had to go for a procedure or go to the OR. And there's no reason not to just say, I'm going to deliver a certain volume and I'm going to give a higher rate versus a lower rate if they break. The other thing that brings up is bolus feeding, which I think is a cool, kind of a cool topic. During COVID, there was a great increase in bolus feeding because we ran out of feeding pumps, and I would get emails from dietitians all over the country. Can I just start bolus feeding because I don't have any more pumps? I ran out. And you definitely can. There's a really good publication from Danny Baer and Zun Puttacherry where they did a bolus feeding strategy with the idea that there's some reason to believe the muscle full theory is true, and that is we as humans don't eat continuously, and there's not a benefit to your muscle eating continuously. Otherwise, bodybuilders all have feeding tubes. There's a really important need to eat and have your amino acid level drop and then have it increase. And that's what stimulates muscle protein synthesis, and it's called the muscle full effect. And so the idea that we should be bolus feeding to preserve circadian rhythm and optimize muscle function was what this trial began to get at. Using muscle ultrasound, they weren't able to show a big difference in the muscle mass of the patients, sort of not super far out of ICU, but during the ICU stay. But they did show improved feeding efficacy and delivery of protein and calories with bolus feeding versus continuous. We bolus feed a lot of our patients at Duke. That happened before I was here. That was a tradition in our surgical ICU. And usually about 180 cc's or 200 cc's per Q3 hours is how it's done. And I think this is a very successful way to get your tube feeds in, and maybe more physiologic as well, with benefits to the muscle and or the circadian rhythm.
Right. This is another sort of weird thing that's always struck me as odd, but that in a lot of places we do continuous tube feeds, but bolus free water. So
Right,
it's
of course.
like we're getting the worst of both worlds, like the logistical hassle of having to do boluses, but like you said, the no fed and fasted state, no diurnal variation from continuous feeds, and then no ability to catch up if, say, you pause tube feeds for a few hours.
Right.
So,
for sure.
So really, from what I'm taking away from this, because this was actually a question I was really interested in, is like, it would be reasonable to approach most patients with a bolus strategy up front and then sort of assess them. And if you're dealing with, again, those high residuals, let's say greater than 500, or, and then perhaps you could back off to a continuous strategy, see if they quote unquote tolerate that better. Is that reasonable, or am I misunderstanding?
I think it's very reasonable. I think if you're going to start in the sicker patient with trophic feeds, maybe then you start at 10 or 15, but then as they move towards full feeds, there's no reason not to try a bolus strategy. I mean, if you think about 200 cc's, it's like this much. Right? The stomach's like making
half a Coke can.
It's a tiny amount. And so I think people worry, don't do that through a duodenal tube, probably. I mean, don't do that through a pulse pyloric tube or a small bowel tube. But in the stomach, I don't think there's any reason not to. We do it pretty routinely at Duke, and I know other hospitals that do it as well. And it makes a lot of sense to me. The guidelines are split on it right now. I think with this new paper and chest from Danny and Zuden, I think that'll open some eyes to the safety and efficacy of it. It's a well done, reasonably large trial. So that may change sort of people's opinions too. But I think there's enough good literature out there to tell people how to do it, and you can do it safely.
Great.
Paul, I know that Nick had actually, alluded to talking about branched chain amino acids, and I have an interest in some supplements as well that I've seen used. So things like glutamine, creatine, testosterone. I've seen in the burn ICU, oxandrolone used before. Things of that nature. And then also, like, we talked about protein, but specific protein goals for all comers. I mean, is there a specific dose we should be looking at? What are your reactions to those sorts of words and questions?
Sure. I mean, I think to try to kind of take them in order.
Yeah.
I think there will still be a role for glutamine. I mean, I think the data redox really hurt that practice because we went with this big pharmacologic dose of glutamine rather than staying with the literature that you use glutamine as a TPN nutritional dose replacement, because TPN amino acids don't have glutamine. because if you don't have them as a dipeptide, they're not stable in solution. So that's the only amino acid US TPN solutions don't have in them. European solutions in Africa and in other countries, they have the dipeptides of glutamine that have been around for 20 and 30 years that are stable in solution. So alanine glutamine and glutamine are stable, but alanine glutamine is the most common. The data in patients who are getting PN supplemented with glutamine, especially oncologic patients, cancer surgery and cancer patients, the meta-analysis data that we published, the meta-analysis still shows a significant benefit on outcome, survival, and complications from the use of nutritional doses of glutamine, not drug doses like we did. And so I do think there's a role for that. I think there's also a role for it in the CRT patient. CRT is devastating to nutrient content of the body. We just published a paper with actually one of our ICU fellows in the middle of the night showed me Slicer Dicer and Epic and was able to pull up every copper level drawn in the hospital like in 5 minutes. Like
Slicer Dicer is great. I love
it's
being
so
able
great.
to answer these questions. Yeah.
We published a paper showing that 90% of patients on CRT more than 5 days will become markedly deficient in one or more key nutrients, copper, selenium, B6, and the complications these bring with them can be quite profound. If you become copper deficient, you could be pancytopenic, which I have seen more than a few times, both in burns and in cardiac patients, cardiac CT/ICU patients who run for a long time, and they will get life-threatening pancytopenia. And you give copper back and it comes right back. If you're copper deficient for a prolonged period of time, you can become permanently weak. You can get permanent neuromuscular weakness. You can actually see the lesions on MRI. So you wonder how much of our ICU-acquired weakness that won't go away was a missed copper deficiency that went on for a long time because they were on CRT a long time. And so that's one of the most common deficiencies, and we replete that aggressively. We try to prophylax against it. B6, I've had more than a few patients that will be on CRT and they'll get stroke workups because they're obtunded. B6 deficiency will cause severe encephalopathy. It looks like they've had a stroke or they're severely encephalopathic. You give 25 cents worth of B6, 50 milligrams a day for 5 days, they wake right up because their B6 levels are zero.
Are you checking these levels or are you just giving the supplement? Okay.
I am. We're working on prophylaxis. So anytime a person on TPN goes on CRT, we double dose the micronutrient vitamins right away. If they're not on PN, we then start a multivitamin with trace elements in it as well. It has to have copper. Carnitine can become very deficient. It's also lost in CRT. And so if you're carnitine deficient, you're going to be very weak because you can't transport fatty acids to your muscle. So we often start bumping our carnitine up like 300 milligrams extra a day. We do check sometimes. Sometimes we just prophylax, depending on how long we think they're going to be on. But at 5 days, we do start checking the levels. 5 to 7 days, we'll send. What I usually do is I send copper and B6. If one or both of those is low, then I send carnitine and selenium. Zinc actually contaminates CRT fluid. It will not get low. You'd think it would because it's another trace element. It's in the CRT fluid as a contaminant and it doesn't get low. It's bizarre. So, but this is a real issue. And we associated it with not doing any fancy statistics, but we associated it with increased mortality if these got low as well. Probably other factors involved too, how sick they were.
Acuity of illness, et cetera. Yeah.
Acuity of illness is higher in those patients too, but nonetheless, the known specific, and the thiamine can get deficient from CRT too, right? Lactic acidosis is a known complication of thiamine. So unexplained lactates in CRT patients, if they're not getting nutrition especially, it could be thiamine. I've had to replete that as well. Vitamin C will hit the ground as well. So we bump the vitamin C to 500 sometimes in their PN because we know we're losing it. And then amino acids are lost in CRT. So we will typically bump them to 2 grams per kilo of protein or even 2.3 or 2.4 because you lose 30% of your amino acid load to the CRT filter. And so CRT is a devastating nutritional toy. You know, it's a dumb kidney, right? It filters everything, including all the nutrients we need, where our smart kidneys would never do that. And so I think people are not very aware of that.
Just to that's like a great discussion of some of the perils of CRRT as it relates to nutrition, which is not really something I think about when I put patients on CRRT regularly. I will now, though. To take a quick step back with the protein dose, you mentioned 2.3-ish for folks that are on CRRT and you're worried about protein wasting. In your non-CRRT kind of generic medical ICU patient, you're targeting 1 to 1.5 grams per kilogram, something like that?
Yeah, there's a really cool paper that we're about to submit to Critical Care, and I'll give you a sneak peek. It's a dietitian in Canada who did this really wonderful work where in Canada, they have these physical therapy scores. They're basically sort of functional scores they do at the end of hospitalization. And his data in a large group of patients, an observational group, found that the best physical function at the end of ICU and hospitalization was found in the 1.2 to 1.5. And it was better than the ones that got fed more. And it was much better than the ones that got fed less. And so, it's just one study in a large group of patients in an observational way, but there is some hint there that 1.2 to, 1 point, so 1 to 1.5 or 1.2 to 1.5, honestly, is probably the best target. In most people, you probably don't need more, with some exceptions, the grossly malnourished patient, the person who, is losing in CRT, a person with a burn wound or sort of a big physical illness or trauma, maybe that's different. But in the average medical ICU patient, 1.2 to 1.5, to me, seeing the data I've seen now, makes me think that should be the target.
Awesome.
And this isn't even published yet, but the data is compelling. It's actually one of the award-winning abstracts at the Aspen Clinical Nutrition meetings next month. And I'm giving you a sneak peek at that data. He's phenomenal.
That's right, folks. You heard it here first.
Yes, we appreciate it.
Yeah, so I do think I think that's a super exciting, and I will be sure to cite he and his group, Chelsea Gillis and his group in Canada who did this work. It's really cool work, and I'm really excited for what he's doing.
It seems like a recurring theme in our conversation, Paul, is this idea of sort of a Goldilocks, zone. Not too little, not too much. There's sort of a sweet spot for a lot of these things, whether it's calories, whether it's protein. It's very interesting.
Yeah, Paul, thank you so much for sharing that kind of sneak peek. And I know we kind of talked a little bit just now about CRT and minerals and some micronutrients. Before I had asked things like creatine, testosterone, other sort of steroid supplements. What are your thoughts on using those in the critically ill?
For sure. So I think the most interesting piece of where I think a lot of our research is going and where I think there's a lot of new data is in the anabolic agent part, the testosterone and oxandrolone field, right? We've known in the burn world, right, that pretty much everybody in the burn world gets oxandrolone as a standard of care, although it's potentially going off the market in the US, sadly. The FDA may be pulling it, which is pretty tragic. Even when I visit burn units in South Africa or India, they're getting it. So even third world countries, this is a standard of care. And oxandrolone, for those who don't know what it is, it's a purely anabolic steroid. So it's like testosterone without the virilizing, the thing that masculinizes you or makes you a male. It has none of those effects. It's like a bodybuilding drug. It's purely anabolic. And it's brilliant in the burn world. It's been shown to reduce mortality, reduce numbers of surgeries, improve physical function, improve bone density. It is clearly a major key intervention in the burn world. And right before COVID started, Rosemary Kozar and a few others of us around the surgical and trauma world had written a trial to the NIH to study it in standard ICU patients. And so we were very interested in that. And then we all got distracted by COVID. But I will tell you that the testosterone data, which is much more readily available, and we don't have oxandrolone in Duke's, we're at a burn center, but testosterone cypionate, which is the IM form, is readily available in every hospital. The data, I think, for testosterone was always caveated with, it might increase clot risk or heart attack risk or stroke risk. Well, that was in the oral forms of testosterone. They go through the liver and get aromatized, and the metabolite causes that risk. There is a large 43,000 patient study in the annals, JAMA Internal Medicine from Kaiser that showed if you're testosterone deficient as a male and you get it repleted with an IM form, you reduce your cardiac event rate 30%. You reduce heart attacks 30%, strokes 30%, cardiovascular events 30%. And then Intermountain Health followed it up with a large trial of 9,000 patients with known major adverse coronary events in their past. So they have real cardiac disease, real ischemic disease mostly. And they had significant reductions in their major adverse cardiac event rate when their testosterone was repleted when it was low. So I can tell you there's literature and my experience, I measure total testosterone in many of my patients. The majority of patients, 90+% are low within 5 days in the ICU. And they'll be like almost undetectable sometimes. They'll be 20, 50, 30, normal's 300. And I replete a lot of them, especially the ones who I'm worried about ICU cord weakness in, the ones that I know are going to be long stayers, the ones that already are weak. It's becoming a bigger and bigger part of my practice, and it reduces their heart attack and stroke risk. And it reduces heart transplant rejection, the data would say as well. So there's even sort of specific populations that have been studied. But it's critical that it's given IM, not transdermally or orally. And it's critical then that you just get, total testosterones come back. They're an add-on lab at Duke. They come back in 15, 20 minutes, and they're cheap. You don't need the total and the free in most patients because the level's so low. It's not like you're measuring the intricacies of their delivery. And then I check another level at a week. So an IM testosterone doses, half-life is 9 days. It's typically dosed in a 70-kilo male, 200 milligrams IM every 2 weeks. So it's given IM every 2 weeks, pretty simple. And then you have to make some variations on that. I do give it to women who have severe ICU-acquired weakness as well. I have a patient on it now, actually. I give, and I target 500 to 600 in the men. That's from the urologic guidelines. I'm happy to share those. There's a wonderful urology guideline to how to do this. And women, I target a little bit lower. I target, 350 to 500 at the most. And I usually don't keep them on it longer than 6 months, but it definitely improves what I have seen in my eyes, strength and other functions and things like that. But those trials have yet to be done in a broad critical care population. I think they deserve to be done. And so, but I think the key here is you can do this safely. You're not going to increase the stroke risk, the thrombotic risk. You're actually going to reduce the stroke and heart attack risk, which is really new data, but now from large trials, large numbers of people. I think the other supplements, creatine is probably the most studied supplement anyone can take. We know it's effective on a number of different fronts, from cognition to muscle strength to power to, basically, if you can lift 10 pounds 100 times, if you take creatine for 2 weeks, you'll be able to lift 100 pounds 20 times or 15 times. So it's an ATP regenerator in the brain and the muscle, a lot of other places. I think those trials need to be done. I use it to optimize cardiac and liver transplant patients. So in patients, they come to me and say, this woman's too frail. How are you going to optimize them? So I start them on creatine, testosterone, or oxandrolone if I can get it. HMB. HMB is a brilliant nutrient. It's in some of the oral nutrition supplements that we use. I've been taking it since 1996. It's an mTOR agonist that stimulates, like leucine, but more potent. It stimulates muscle synthesis. It was developed for wrestlers to gain muscle without weight by Iowa State. There are many, many trials of it. There's meta-analyses of it. There's a trial that's about 670 patients in 76 centers. When you give an oral nutrition supplement for 90 days after hospitalization, it reduces mortality by half. The number needed to treat is 20 for every patient. Every 20 people you give an HMB-containing supplement to, you'll save a life in the first 90 days. It's actually more cost-effective than the influenza vaccine when you do the data. So this is something we all could use. I've been taking it since the early 90s because I grew up as a personal trainer in a bodybuilding gym to make money because the gym at University of Chicago wasn't air conditioned. And I ended up at a gym with Sergio Olivia, who beat Arnold a few times, and he was the person who got me. And they all took it. It was religion to them. And so I figured they knew more about physiology. I learned more about physiology and nutrition in that gym than I ever learned in medical school. But I think HMB is our go-to supplement, our oral nutrition supplement. I encourage all my pre-op patients and my ICU recovering patients to take it 3 grams a day. You can buy it. Anything you're going to buy supplement-wise for a patient post-ICU should come from NOW Now Nutrition. They don't pay me to say that. Everything I take comes from them. You can get it on Amazon. They're the only GMP supplement manufacturer I trust. When we do NIH trials with nutritional products, we get them from the Now Nutrition Group because they're GMP and pure, and we've tested them. They're stable. But I think HMB and creatine do have a really potent set of literature. They're safe, they're efficacious, they have great clinical outcome data in a lot of settings. And so I think those are the 2 sort of oral supplements. And then I encourage my patients to take branched chains at night, not so much for the encephalopathy. I think that data is soft. But we know that if you take in whey protein or branched chains at night before you go to bed as an elderly person, you gain 17 to 20% more muscle mass. This is true probably for everybody because you're anabolic overnight. That's when we release growth hormone and testosterone. And so I want all my patients taking in whey protein or branched chains. I take branched chains at night to make sure those essential amino acids are present when you're releasing your sort of anabolic milieu over the night period. And so that's when I intervene with those and have patients take them, especially at home in the post-ICU period.
Excellent. That was an amazing summary of
wow. I'm like
supplements. And by the way, I'm adding things to my Amazon cart as we talk. So
oh my God, I was doing the same thing. I was literally doing the same thing.
I'll have to send you the list. I have a list of everything I take every day for reasons we can talk about in a minute. But when I travel, I have to take a separate suitcase for this stuff. But I think it's helped save my life for various reasons. And I've sent this to many, many patients around the world. And I've had many people come back and say, God, I'm a totally different person because I use these evidence-based interventions to help me recover or prepare for surgery or recover from ICU.
That's great. I want to pivot to talking about exercise, but before we do, I want to ask you just one more question about nutrition. Several times in this chat, we've talked about people who come in with pre-existing malnutrition. How do you approach those people differently?
So they are different, right? I mean, and I think a lot of us believe this comes back to sarcopenia and low muscle mass. So more and more, there's a lot of us becoming sort of muscle physicians, muscle-centric physicians. I think you're going to see some papers coming out soon that we're writing right now that muscle is the most important organ in the body. It's also the biggest, not the skin.
Take that, dermatology.
The muscle's super important, right? And so the amount of muscle mass you come into critical care event or surgery with is really your metabolic reserve. It's really that thing that's going to either get you through it and have you survive or not get you through it and have you end up either frail or not surviving at all. And there's robust data for that, right? We know patients with low muscle mass or low muscle quality, which is how much fat's in their muscle. So intermuscular fat measurements can be done by CT or ultrasound. We do them routinely. Those measures are highly predictive of survival independent of everything else going on. So we also know, right, the best BMI to get sick is what? It's 31. So everybody's got to go out and gain some weight because, don't get hit by a bus if your BMI is 22. I'm usually in audiences with a lot of dietitians who are very fit, but they're also usually very thin. And I always tell them, none of you guys should get hit by a bus. You're way too small. So, but that BMI is not really the magic number. It's the muscle mass that's associated with that probably, right? And so that is critical. And so I think the malnutrition patient needs nutrition earlier, right? Those are the people we start TP in at 24 to 48 hours. We typically maybe ramp up. We still ramp up slowly, but we try to maybe get to goal a little quicker. We want to make sure they're getting their goal routinely. They can't miss. They can't have days they miss. Sometimes I'm checking zinc and copper and selenium on those patients if they've been malnourished or they have, let's say, have a GI disease with diarrhea or other sorts of things. So they tell me, God, I've had this tumor that's been obstructing my stomach for months and I've been eating a third of what I usually eat. I'm checking for micronutrient and vitamin D deficiency. That's the other key thing for muscle. Vitamin D has to be normal for muscle to be formed. So it takes 50 to 100,000 units of D3. D3 is key. Sometimes a couple times to get an ICU patient up. We know from that one JAMA paper, 500,000 that was done, reduced mortality and was safe. So you can even give bigger doses, but I give 100,000 in the ICU and 50,000 on the floor, usually for about 6 weeks. So D has to be normal. But I think the malnourished patient is really critical that nutrition needs to be started sooner. PN is started sooner in those patients just by default because, we don't want to wait. And our guidelines support that. Our guidelines would say those patients should be started on PN within the first 24 to 48 hours. And I still would ramp it up, though. I still would do that ramp because I think our evidence is strong enough to say we should all be starting go slow and then ramp up pretty much in everybody. But malnutrition and particularly muscle mass. So I can tell you the Harvard hospitals, and I'm a little jealous, they report out muscle mass from the L3 cut on every CT they do, and they're getting Medicare to pay for it.
Wow.
So I want everybody to go out and get their hospitals start doing that. We're trying to do it at Duke. We have the software. The software is free. Slice-O-Matic is the software. Dietitians do this on their own. Sometimes they draw out the muscle, but there's a software that'll do it automatically too that we have now at Duke, and that's what Harvard's using. But those kind of data, I think, are standard. Now we do it by ultrasound as well. There's a device called the Muscle Sound, and I do advise for them. I'll disclose because I'm super excited about this device. It's about as big as a mouse. It plugs into your iPad or iPhone, and you can muscle mass, muscle glycogen, which tells you if your patients are eating and if their muscle's taking it up. You can measure glycogen without a biopsy, and muscle fat, intermuscular quality. All is measured in 3 minutes. And so I hope every dietitian and physician has one of these in their pocket someday, and it will be to the dietitian perhaps what the stethoscope and blood pressure cuff is to the nurse. And so it's a way to then see if your patients are actually taking their oral supplements. It's a way to look at if their body's utilizing them. I think it's a transition from acute to the recovery phase because the muscle glycogen will stay lower than a marathon runner even for the first couple of days of acute illness and shock. And then it'll start to climb up, and that's when they can actually utilize the substrate, and tube feeds probably should go up. And so there is probably an objective way to measure that. And we do a lot of that in our optimization programs.
Interesting.
So that's a direct way to measure malnutrition, right? The new GLIM criteria require muscle mass measurement. Now insurers are starting to ask for it even. So either CT or ultrasound or BIA, but ultrasound is the most usable bedside way to measure muscle mass.
We love point of care ultrasound on this show, but I gotta admit, I've never heard of that before. That's really fascinating.
And you could do the temporal muscle. We had an abstract at SCCM. I don't know. I actually ended up presenting it for one of our physiologists who couldn't come. That correlated the intermuscular fat content of the temporalis, because this is super easy to measure. It doesn't matter how much edema you have or anything else, with their CPET VO2 peak. So it actually predicts cardiopulmonary fitness, even measuring the muscle quality or muscle fat infiltration of the temporalis muscle. This is a pretty robust muscle. It's slow and fast twitch because it's got to keep your jaw and make you bite. So it's a great mixed muscle. It's very easy to access. You can get it to everybody. Edema doesn't affect it. We're using that more and more. We do the legs as well. We do the rectus as well, but we really think there's a big future for the measurement up here.
That's so cool. That's a great bookend to what you were saying about how you can't fix things that you don't measure, and so having an objective tool to measure pre-existing nutritional status is really key.
Yes, because it's hard. Obese patients often don't have the other obvious physical signs of malnutrition, but the large population of our patients are obese. Many of them have very low muscle mass and are at great risk, and no one notices them. Everyone wants to put them on a diet, right? Which is the worst thing you can do. There was a great Journal of Clinical Investigation paper in the 90s that showed that in trauma patients, obese trauma patients, you think they have all this fatty acid store. They are exceedingly poor at accessing their fatty acids when they're traumatized. So a lean individual can get about 60% of their caloric needs from their fatty acid production when they're injured. An obese person's about 30%. Wow. So they tap their muscle and waste their muscle faster, even though you think they have all this caloric sort of advantage, they can't get to it, which is why they got obese in the first place, right? They don't metabolize or utilize fat effectively. So when they're stressed, it gets even worse. And then we put them on a diet. We're like, oh, you got to underfeed them because they don't need the calories. That is totally wrong. Never put an obese ICU patient.
If they're lucky and they make it out of the ICU, they now have sarcopenic obesity to add to their list of problems.
It's devastating.
I think that's actually the perfect pivot point too. I know you gave a talk recently about this, but do you want to tell our listeners how sarcopenia affects outcomes in critical illness and illness more generally?
Yeah, it is really one of the most profound predictors of adverse outcomes, not just in surgery and ICU, but in your life, right? I mean, the quality of life and the longitudinity, or the length of life is much greater the more muscle mass you have. And the reality is we lose a certain percentage of our muscle mass every year we age if we don't do something about it. You don't have to lose muscle mass as you age, but many people do because we become anabolic resistant, which means it takes more grams of protein to build the same amount of muscle for every year you are older. And it starts at age 21. And then especially you get in your 60s and 70s, even your 50s, you can lose significant percentage of your muscle mass every decade, every year, if you don't begin to do things like resistance exercise. And more of the exercise world is coming around to say resistance exercise is more important than cardiopulmonary exercise because it's what keeps you from falling on the ice. It's what gives you the reserve when you get injured. It preserves cognitive function in a way we don't fully understand yet, but is better than most other things. And it's actually a better anti-tumor agent exercise is than chemotherapy. There's a lot of studies in many kinds of cancer now that show that. And so the muscle you have that as you age is what's going to give you quality and length of life and cognition. And so it really is sort of our master organ of longevity. But it takes more protein to preserve it, and it takes more resistance exercise when we're older than when we're younger because we begin to lose it. And so it's really critical that we then, for our patients, are emphasizing this before they have their big surgeries, after they've been in the ICU, that cardiopulmonary recovery is key. And we can talk about some cool studies we have doing that with some of the CPET testing we do. But muscle preservation is the thing I drill to my patients. I'm like, I want you doing sit to stands in the bed. Even just the movement of sitting to standing is a huge benefit of exercise. Neuromuscular stimulations. We've done some studies with neuromuscular stim and cycling in intubated patients. A lot of athletes use that. Anything and everything. We put bands on the bed. I have patients bring dumbbells in for their families, bring in for the patients. Anything we can do to preserve muscle mass or pre-add it to patients prior to big operations, transplants and things is so critical. And so the data, I think the data that's most compelling is in cancer. If you come into chemotherapy or cancer treatment for major cancer and you have lost weight before that, your average length of life is about 7 or 8 months. And this is a big study. If you didn't lose weight or you didn't have low muscle mass measured by CT and you come into cancer therapy, you live 2 years longer on average. So that's the preservation of life, that just having robust muscle mass. So having sarcopenia or weight loss before cancer therapy, you're going to live 2 years less than if you had good muscle mass or hadn't lost weight and came
That's
into
an
cancer
enormous
care.
effect size. I mean, that's a comparable effect size to many like immune checkpoint inhibitors and other like breakthrough
Easily.
drugs. Yeah, really
Easily.
amazing.
And you can lose 10% of your muscle mass. So if I laid a 21-year-old down in bed for a month, they wouldn't be able to walk. NASA did those experiments, right? You lose somewhere between 2 and 5% of your muscle mass. If you're elderly, you could lose that 5 times that muscle mass. You can lose 10% of your muscle mass in 10 days just laying in bed. So the bed is evil. I tell all my ICU patients every day, I don't want to see you in the bed, but at night. Beds are for sleeping. They're evil. They cause death and disability. I want you in the chair or walking the entire day. And I'll tell you that I practiced what I preached myself. And then if you are elderly and critically ill, you lose 10% of your muscle mass in 3 days. And these are with muscle tracer studies. So these are really accurate studies. So the bed and the illness is devastating in our older patients. And so it is just something that we have to be aware of, and we've got to get our patients out of these beds, because the bed rest alone is devastating, much less the illness. One neat thing about HMB, there was a really well done study by the editor-in-chief of Clinical Nutrition. He's a really famous muscle physiologist, Nick Deutz, looking at HMB, that supplement I told you about, the oral supplement. It will completely reverse the loss of muscle in the bed-rested elderly patient if it's given at 3 grams a day, using muscle tracer and other advanced muscle physiology techniques. So one of the advantages of this HMB particular supplement we really like is it reverses the muscle loss of bed rest, which is often the most devastating muscle loss the patient sees, because even when they're past the critical illness, they're still in bed often for weeks, and they're losing muscle every minute they're in the bed. Beds are evil. For sleeping and procedures.
Point made. You've alluded now, Paul, like a number of times to your own personal story, and I certainly would love to get to that. The one thing I wanted to do is sort of, make the rubber meet the road, so to speak, and just give us like a theoretical situation with a patient, and just kind of get your idea or get your thoughts on how you might approach that patient.
Sure.
In regards to ensuring they have the best outcome possible.
Yeah.
So suppose we have like a 65-year-old patient, previously healthy, active, jogs daily. And this guy, unfortunately, he gets admitted for a basic appendectomy, but it ends up being complicated by septic shock. He has multi-organ failure. He ends up with ARDS. He spends time in the ICU. Unfortunately, he's not in your ICU, so he's not ambulating. He is, unfortunately, in bed longer than we would like him to be. Yeah. And so ultimately, though, he gets through his illness. He's extubated. He's eager to get back to the way things were before all of this went down. But he feels profoundly fatigued, and really feels like he's lost quite a bit based on where he is now versus where he was a couple of weeks ago. So obviously, we've talked a lot about how you might try to prevent this, and hopefully our listeners will now have those tools in their toolbox to use, up front. But I think you probably agree, more often than not, this is the story that actually plays out. And so what do we do on the back end to try to help this guy recover?
For sure. So I can tell you sort of the proposed pathway, and we've done this with a few patients, and we're doing it in some trials. And in the dream world, what I would do, and then I think listeners can begin to think about what they're capable of and how they might evolve to some of that. So one of the first things we would do, obviously, with a patient with that is we would address nutrition, right? So this person's eating perceivably now. We know they're not going to eat enough food. So we can't expect someone to say, go home and just eat more. That's not going to work. So they need to be essentially started on an oral nutrition supplement. I wish they weren't called supplements. It makes them sound sort of optional. We call it oral nutrition therapy, these protein drinks, right? And for most people, they're not going to go home and make a whey protein shake, which I wish they would. Wish they'd throw some berries and some whey protein and some honey together and put it in some milk. But most people are going to drink the Ensures, the Boost, the different kinds of drinks that are available. Ideally, that would have whey protein in it. That's by far the best protein for building muscle for anyone, even a sick person for sure. But casein protein, which is what unfortunately a lot of them contain, is okay too. But you want to get at least 3 of those in a day. When I go into the room in the ICU every day, I'm like, I want you to drink this protein drink before you eat any of the food. It's way better for you, and it's going to give you much more of what you need, and the food's bad anyway. So, I mean, you're not. So what are you going to do? So I think getting to protein goal is the most important thing. And you need to get above 1.2 grams per kilo per day, ideally 1.5. And so I tell patients, I want you to target a gram per pound of weight. not many people get there, but it gives them a really simple number in their mind they can kind of chase. Because in the recovery period, right, we found you need more protein and calories to gain weight. Going back to even the most famous nutrition trial ever done, the Minnesota starvation trials, where they starved soldiers, volunteers who didn't want to fight, under the football stadium at the University of Minnesota to see how much food was needed to restore Europe and Asia when all the starving people were after World War II. Starvation killed more people than the bombs and bullets did in World War II. And so those patients took 4,000 calories a day to recover, and they were healthy 21-year-olds and a lot of protein. They tried to resuscitate with 2,500, didn't work. So the patients need more protein and calories, and they're only going to get it from that. So that's the baseline. You have to have that. That's the foundation of good nutrition is protein goal 1.2 to 1.5 gram per pound. Ideally is the way I teach that to them. I want them to count. I want it to be whey protein. They have to drink their old drinks 3 times a day and 1 before bed, ideally. So 2 times a day and 1 before bed is the best. Then I began to see what are they willing to do? Are they willing to take some HMB? That's pretty easy to take. It's in some of the protein supplements or the oral drinks. Are they willing to make sure their vitamin D is normal? So we got to check their vitamin D and get that normal. Are they willing to take some creatine often? Sometimes I even get it in the hospital. I get the pharmacy to get it, especially in our CT side. That's CT drives Duke, and so we can get anything we want. But anyway, some of these supplements matter, but the vitamin D at the very least and the protein at the very least. And then the HMB containing supplement when I can get it for them. And so that's the baseline. Then in the ideal world, and I can tell you in COVID, this is what we're doing. We do cardiopulmonary exercise testing at the bedside. There is a Bluetooth mask. It costs $2,000. We have validated a step test. They can step in place in their hospital room or in a rehab center. And in 5 minutes, we can get their VO2 peak and the heart rate at that VO2 peak. And we have got an exercise program we've designed. It's a high intensity program. It's really moderate intensity, but it targets their ability. So we know what we want them to hit 85% of their VO2 peak and 85% of their heart rate, and then they come down for a minute. We have them do that 10 times, 3 times a week. It's called RIM Hit COVID. It's a multi-center, multi-million-dollar grant that actually SCCM funded the pilot for. Wesley and myself and Matt Mart at Vanderbilt, we did the pilot with this, and then it went on to a $4 million multi-center R01 in COVID. And so we're enrolling patients actively across the U.S. in multiple centers who've had any kind of COVID, whether it be ICU or hospital, because they have such profound low VO2 peaks after COVID, and the long COVID's so bad. And we send them home with an iPhone and an iWatch, and they 3 times a week do these exercises along with some strength and balance things that have been validated in a CHF trial that our PT that Amy Pastovo did. And then we have our MICU physical therapists coach them twice a week over the iPhone, looking at their heart rate intervals and coaching them to do them correctly. Usually they don't recover well enough and they don't hit the right targets, but we can see them real time. And so we did this in a bone marrow transplant population to get the preliminary data. We improved VO2 peak 25% in 4 weeks. They exercised 120% of the times we asked them to. So they exercise an extra day a week because they get so motivated by it. And we have these profound improvements in a lot of the outcome measures that we see, and it happens very quickly. The least fit people have the biggest gains with this kind of targeted, personalized, and this is exercise prescription now. We prescribe exercise in this pathway like you prescribe a drug in a personalized, and then we transition them up as they improve. So it changes in intensity as they improve. And then we bring them back in 3 months and we test them again. And so, we're about 40 some patients into our goal of 140. But in my dream world, we would do this with ICU patients, right? And that's sort of the next study.
I can imagine that this could be in the future. This could be like what happens at, as you recover from critical illness. You get a baseline.
This is the post-ICU clinic pathway.
Yeah, CPAP measurement and then exercise prescribed. I love the telehealth aspect, the smart watch aspect. That's brilliant.
Yeah, if you guys want to learn more, it's I can send you handouts and stuff, but it's also on NIHtrials.gov, obviously. It's called RIM Hit COVID. But you're right, it's exercise prescription. It's what I dream the ICU rehab clinics of the future will all do. We get about 80% compliance in our COVID patients. They're not quite as motivated as our cancer patients, but pretty motivated. So we've been doing pretty well. We've already had our first DMB meeting and things. But this is what I imagine as the future. I also imagine as the prehabilitation that we will do for patients as well before major operations, transplants, and the like. But the post-ICU setting is the dream here. And the ability to do this with patients in a very structured exercise prescription method that involves strength and balance, and then this cardiopulmonary. And we can teach them to do any exercise. They can do a bike, they can do walk upstairs, they can do sit to stands. Some do it just walking up a hill outside. We tailor them and meet them where they're at. And our physical therapists teach them, like some of them belong to gyms and they want to do it in their gym. Some of them have never exercised a day in their life. And so they do it sitting to standing, or they do it walking up a stairway, or they do it walking down the street.
And are they
so
getting nudges to remind them? Is that part of the program?
They do. We know what their compliance is every it's 3 days a week, and we know the days they don't, because we have every minute they have the watch on, we know what they're doing. And so we know the days they don't exercise. They get interacted with 2 to 3 times a week. Sometimes they actually come back, and we do some of them in person. Some of the older folks who've never done a day of exercise actually like to come back to our rehab center. We do this in a nice posh rehab.
They have a trainer.
And it's like having your own personal trainer in your home. Or if you want to, it's free. And so it's been a really fun study, and I really think it's the future. And just knowing what our cancer outcomes have been already, it's really successful.
So it sounds like, Paul, kind of bringing things back to this patient in particular, like in general, if we want to give our audience some pointers, it would be, you've got to have the foundational elements, and the foundational elements would be appropriate protein supplementation. You need protein to build muscle. We know that. And you're targeting like a gram per pound is what you're telling these folks to target. On top of that, we're discussing, things like making sure vitamin D levels are appropriate, making sure, you've got some creatine and ideally some HMB on board as well. And that's kind of the second pillar, if you will. And then the third pillar, which perhaps is the most important, is, just because you're feeling weak doesn't mean we're going to, take more time away from the gym or from exercise. Like, this is the time we need to ramp it up in a graded manner, but we have to be very purposeful about it, and thoughtful about it. Right. And so if we're able to sort of marry those 3 things together, with a little bit of patience, we can hopefully get that 65-year-old back to his running routine and those other things that make him who he is as a person.
And the last thing I would check is total testosterone.
Okay.
And if it's less than 300, really, if it's less than 250, especially, I'm repleting it. I'm going to start them on 200 every 2 weeks for the next 6 months, because I really, really think it makes a difference. And I think, the key to doing any kind of study like that is the other components have to be there too. You can't give testosterone without giving enough protein. It won't do anything. It's like trying to start a fire with no wood. You can have all the lighter fluids you want, which is what the testosterone is. Because the dietitians, and you probably as critical care docs, have seen lots of patients you feed and feed and feed. You're feeding them 40 kcals per kilo, and they're not gaining weight. And that's true in the burn unit too. A burn child will remain catabolic for 2 years after their injury, and you can feed them perfectly the whole time. They'll put fat in their liver and fat on their extremities until you give them oxandrolone or testosterone and or sapropranolol, which is an anti-catabolic we use in the burn world. They won't gain muscle. But as soon as you put them on anabolic agent or start some beta blocker in those patients, especially burns, they start making muscle. They don't have the anabolic signal, and that's what the testosterone is, that key other arm, right? Lots of people gain weight after ICU. Margaret Herridge and her data showed that they gain weight over the first year, but it's almost all fat because they have no anabolic signal. And I think there's a role now, especially that we can reduce cardiovascular and stroke risk with it and feel safe about doing it in a thoughtful, measured way. That's the other piece of what I think a good post-ICU rehab clinic will do for people is we'll learn to titrate these things that will get people their lives back in combination with the nutrition and exercise that have to be present for anything else to work. And we'll be able to hit every pillar of what it takes to recover and normalize someone's life in the physical sense. And in the cognitive sense, too, there's benefits, too. But
and I think it's really important to emphasize, what is required for somebody to achieve a reasonable quality of life. Peter Attia talks about this, like being able to lift a bag over your head to put it in the overhead compartment. That's surprisingly difficult for a lot of people, especially depending on what you pack. But think about the implications of not being able to lift a gallon of milk. Right? Like your ability to go shopping, like just like fundamental day-to-day things become extremely challenging when people become sarcopenic after critical illness. And we're doing people a disservice when they survive the critical illness, but they're not able to do the things that gave them value, anymore.
Yes.
That's such an important point. Like
and
it's
there's no
kind of
reason
getting, it's like returning that patient to kind of personhood, if you will. It's something that I think we often forget about when we're in the throes of critical illness.
And that's what they came to you to recover. That's what they came to us to give them back, right? I lead every lecture I give with, every day on rounds, you need to talk about not just what you're going to do to get them to the next hours and the next day, but what are you going to do to give them their lives back when they leave? So every day on rounds, right, you got to talk about the acute things you're treating, but you also got to talk about on rounds, what things are we going to do today to ensure this patient in 6 months is going to be able to put that bag in the overhead, is going to be able to walk down the street with the people they love or hold their grandchildren ever again. And those things have to start when they're ICU. They have to start in the post-ICU period. They have to start when they're on the floor. And how are we going to coach people at home? We've gotten them into this position. Now, how are we going to give them their lives back? And that should be part of rounds every day.
Paul, I think that was really a great discussion of exercise. We could talk a lot about that. We've already been chatting for quite a while. I do want to kind of lead us into part 3 and let Nick kind of ask the question that we've all been waiting for. Nick, I think you wanted to ask Paul a little bit about his past.
Yeah. So Paul, often when we have guests, we like to ask them, what their superhero origin story is. Like, why did they decide to do what they do with their life? So Paul, what made you so passionate about this important topic?
Yeah, it's a great question. I think I get a lot of questions too. What is it that makes you as an anesthesiologist, critical care doc so passionate about nutrition and patient recovery and all this metabolism stuff? It's just not something we do as ICU doctors. But I can tell you it started when I was a teenager, when I was 15. And I can tell you when I was 15, my dream in life was to be an Olympic soccer goalie. And so it was very far from where I ended up. And then about December of my freshman year of high school, I was playing on the JV basketball team, and over Christmas break, I got strep throat, and I got prescribed an antibiotic, erythromycin, and it caused some GI upset. But the GI upset persisted and got worse, and soon I was in the bathroom 15 and 20 times a day, and I was bleeding, which I had never imagined seeing when I went to the bathroom. And I was stooling and bleeding, and so my mom, of course, took me to the doctor, and that was when I realized doctors weren't very nice people. And they really didn't see you as a person. They saw you as a job to be done. And so they did, colonoscopies back when they didn't sedate for them at all. And they would always tell me, this is taking longer and this is harder because you won't hold still. Now, I remember I'm a 15-year-old getting a colonoscopy wide awake, who's already in a fair bit of GI distress from the illness that I'm ultimately going to have. And then I went through a whole range of procedures that I realized physicians were not nice people and that this is not what I imagined what medicine was supposed to be about. And they ultimately diagnosed me with ulcerative colitis. I remember they came to me one day and they said, you're going to get admitted to the hospital and you're not going to eat anything for 6 weeks and we're going to feed you through a tube. And I'm like, the hell with that. I'm going to play basketball next week and I got a game on Tuesday. And they're like, no, that's not happening. They're like, your hemoglobin is 3. And I didn't know what that meant. And they said, you won't live long if you don't come into the hospital right now. And so I did and began to discover the other unpleasant things we do to people and don't think twice about. I was a hard IV stick. So I got stuck 7 times that first night over 6 hours by 4 people. It was the most traumatic single event that I had ever had in my life. And one of the most traumatic events I can think of now in my life, being stuck as a child, not knowing what was going on. Over the next 3 months, I got 40 units of blood, was MPO the whole time on TPN, which was my first experience with nutrition and dietitians and pharmacists. I lost 60 pounds from 160 pounds to 98 pounds, was a real skeleton of myself. And then finally, when they let me start taking in co-liquids again, I remember my abdomen got real hard and I got a fever, and some German guy came in and shook my abdomen, which hurt a lot. And he said, well, you're going to have surgery tomorrow. You're going to die tomorrow night. And I think they thought I would be against it. I'm like, God, can we do it now? So I had developed a toxic megacolon for my ulcerative colitis and it perforated. And so it was rushed to the OR, ended up in the SICU. That was my first SICU admission at age 15 at University of Chicago. So I was a patient at University of Chicago before I was a medical student resident and fellow there. It was ironic to care for people in a room I lived in for almost a year while I was there.
Literally the same room.
Literally the same room I would see patients in. It was one of the surgical GI floors. And so I was pre-oping people there all the time. And I would look at that room and think, God, this was my home for a year. Suffered some pretty significant delirium, discovered the terrors of Haldol. I had a surgery resident, I was seeing trees and birds and deer, really pleasant hallucinations in the ICU. And they're like, oh, we can fix that. We'll give you some Haldol. And I got the Haldol. And the first night I felt like I fell through 3 glass floors and suddenly my hospital room had like 10 levels. My body shattered on the ground into a million pieces. And I spent the rest of the night putting my body back together piece by piece, which you can imagine when I described that to the surgery resident, they're like, oh God, this teenager's crazy. He's like, you just need more. So the next night they gave me a bigger dose. And then all of a sudden my arms went up, my eyes rolled back. I started hearing voices and I couldn't move. And the poor nurse, been a nurse about a month, is like, this kid is crazy. course, I was dystonic. I sat
Right.
there for 8 hours like that before the senior resident came back from the trauma he was in and said, oh, he's having a dystonic reaction. Maybe you should give him some Benadryl. But I have profound memories of the dystonia, and I had a tremor for a month. So these were my early memories of sort of, I think, a lot of things around. I don't feel like physicians really put patients first. And I felt like it was the medical students and the nurses were my only friends. And they're the people I really connected to. And I thought, I want to become a physician. And I hope I can teach people to do this better and to care more and to realize this is a person laying in the bed, not a job to be done or a box to be checked. And then I said, I want to do research on things that don't make me sicker than the disease, because all they had was prednisone and steroids and hydrocortisone back then. And I made me crazy and hungry. And I wanted to be a chef because I was so hungry and I couldn't eat. But they never made me better. And I said, God, I want to study things that I think can make people better without more side effects than the disease you have. And so that's sort of where I began to get into nutrition. And so I went back to the GI doctors who cared for me my freshman year of college. And I said, teach me to do research. I'll volunteer. And so that was when I started in the lab working for the GI docs at the University of Chicago who cared for me as a patient. And that evolved to projects that began to focus on glutamine and nutrition interventions for inflammatory bowel disease. And then ultimately I ended up at Mayo working with they had done most of the work in that kind of ulcerative colitis. I had a ileal pouch for 5 years. I was the first kid in Chicago to have one done, and it failed miserably, sadly. So since that time, as you mentioned before, when you have ulcerative colitis in your colon, they tell you you're cured. The problem is when you're septic and you have all those surgeries and you have a failed ileal pouch, you have a ton of adhesions. And so pretty much every year for the rest of my life until this last year, and I'll tell you why, I was admitted at least 3 or 4 times with bowel obstructions. And that led to innumerable surgeries, 27 now in total. And to sort of shorten that, so I ended up going back to medical school at University of Chicago and I thought I would choose GI, but I ended up, like I said at the beginning, falling in love with ICU and the acuity of it all. And I thought it was a great chance to meld my anesthesia sedation skills to relieve pain and take away suffering. So I sedate for central lines. I sedate for A lines sometimes even. There's a ton of ketamine. There's a ton of Versed. Because I used to, like even IR, right? I can remember at Mayo, I had some surgeries in IR. They would sit there for hours jamming that spike into your glutes to drain an abscess. And they would always tell me it was my fault. It was going poorly because I wasn't holding still. And no sedation, no nothing. Just lay on a hard table and let us put a spike that feels like a bullet going into your back, down into your glutes all day. So I'm a heavy sedator, and I just feel like there's no reason patients should suffer. But to fast forward that, I was having about every 8 years, I was having 2 or 3 more surgeries and losing more and more bowel. So now I have 140 centimeters ish of total bowel, no colon, no ileum. So, and then I have an ostomy I've had since I was 15. And I always like to show pictures of my ostomy to my patients because I take care of a lot of ostomy patients at Duke, and they always tell me I'd rather go to hospice and die than have an ostomy, and I'll never do anything. I'll never live. And I'll be like, there's nothing you couldn't do before that you can't do with an ostomy. But I think something remarkable that ties to the nutrition story is in 2014, I had a bowel obstruction and ended up flying back to Colorado when I worked at University of Colorado with a lactate of 10, ended up in the OR, ended up on TPN for three weeks, sorry. Wrote my own TPN, 2,500 calories, 1.5 grams per kilo. I was really fit. I thought I didn't need much more than that. I lost 20 kilos in 17 days. I went from 235 to about 180 in like 17 days. Couldn't walk down the hospital hallway without being short of breath. And I was running, 5-7K a day before that and lifting every day. Couldn't pick up my own youngest son, who was 5 at the time, 3, 4, 5 months later at Christmas. Took me 2 years to gain it back. And I was much younger than I am now then. And so it took 4,000 calories a day and 2 grams per kilo and all those other supplements I talked about to really get back to where I started. And so I had always taught, and till last year, I taught that it was impossible to be critically ill and have major operations without losing muscle mass and strength. And this was just part of the game. And then you had to get it back. So in 2022, I started having recurrent bowel obstructions again. And actually, this time it was tethered to my ureter. And so I was getting hydronephrosis and kidney failure every time my bowel got obstructed because the ureter was tied up in the gallbladder and the intestinal sort of adhesion. And so I went to my bowel transplant surgeon in Sudan here at Duke, and I said, you got to fix this. I can't, I'm afraid. One of the obstructions happened in Hawaii when we were scuba diving and surfing, and I wouldn't let my wife in, and they read that I had a colon on CT when I hadn't had a colon since I was 15. And so I'm like, somebody's going to kill me at some of these outside hospitals. We were afraid to leave North Carolina. So we agreed to have surgery in April of 2022. And she's like, this is going to be a big surgery. And I don't know that you won't end up on TPN the rest of your life if I have to take too much bowel. But I said, it doesn't matter. I can't live this way. So she did a 14-hour surgery, resected another 20 centimeters, which is where I am now. And then I ended up my own SICU. And the next day I was walking, doing all my things, had a metabolic cart before surgery, had a CPET test before surgery, did all the optimization things you heard me talk about today myself. Knew what my energy expenditure was. It was 3,000 resting. So I was misprescribing my TPN dramatically. Started on TPN day 2 because I knew after that big surgery, it might be a minute till I ate enough. And then the third night I was doing pretty well and looked down and my gown was soaked. I woke up and had a fever and there was stool pouring from my incision. And I was in my own SICU at this point, being cared for by my own nurses. And I had developed an anastomotic leak that she rushed me back to the OR with in septic shock. I ended up intubated in my ICU. 2 surgeries, she couldn't fix it. I had an open GI fistula, which was my greatest fear in life, right? I began to think I'll never see my kids grow up. You guys know what happens to these fistula patients. Sometimes they never leave the hospital. Sometimes they never recover. It's as sick as I've ever been in my life. I really began to question, would I ever leave the hospital? It was like my greatest fear. And so at this point, I'm thinking, God, I'm never going to be physically active again. Probably this is the sickest I've ever been. I'm the oldest I've ever been. I've never been this far gone. It took me 2 years to recover last time. But this time it was different, right? I knew how many calories I needed, and I immediately began to do physical therapy. I was out of the bed immediately doing squats in the room, using rubber bands. And we added an activity factor that I got from my iWatch because I know how much activity I usually do. My iWatch tells me how many activity calories I burn. 4,000 calorie TPN is what we wrote for me. And I started on that right away. And I went home on that, which I would never have written before. I've never written anything like that. 4,000 calories, 2 grams of protein, a better lipid. I've been on testosterone for a couple of years now because I don't reabsorb cholesterol because no helium. And so my testosterone's quite low. I was getting fractures and I didn't know why. Stayed on that and started exercising with my TPN, with my fistula drain, with my open abdomen, with everything. I started on my Peloton with the light weights and then learned ways to isolate out my abdomen. And the interesting thing was usually I could see my face wasting and getting thinner and thinner. It wasn't happening this time. And when I went home, I'd only lost 7 pounds. And I'm like, how is this possible? I lost 7 pounds, and this is the sickest I've ever been in my life. I was in the hospital for a month, in the ICU for a long time. And I was just as strong. And I couldn't believe it. And so I went back to doing things. I began to ask my surgeon, can I lift more and more? You know, this you can't lift more than 5 pounds thing is a bit absurd that one size should fit all in how we exercise people. And then at 8 weeks after my last surgery in August, my wife and I danced competitively. We're Argentine tango dancers. I said, we have a competition and we really want to do this dance number. And I go, it involves me lifting my wife over my head 5 times. And she said, does she weigh more than 5 pounds? And I'm like, a little bit more than 5 pounds. And she's like, do you think you can do it? I said, I think I can. And we did it. And we did the whole routine. And I was just as strong 2 months after I left the hospital this time as I was when I went in. And I regained all the weight within 2 weeks of being home on TPN. I was on TPN for 4 months. The fistula closed, thankfully. And I went back to work in September. And it completely debunked all the myths that I believe to be true about what illness and critical illness does. You don't have to lose weight. You don't have to lose muscle. But you've got to hit calorie targets. You have to measure. You have to have people get active immediately. They have to stay out of the bed. I lived in the chair. I never was in bed. And then the anabolic agents matter. And they have to be willing to do it at home. And it was a miracle.
Well, I'm beside myself. I don't really know. I don't really know what else to say. I can't. I mean, as someone, and I know Nick's very physically active as well. You know, I do quite a bit of lifting when I'm not at the hospital. It's like my passion, and I, try to do whatever cardio I kind of need to, so that I don't feel too bad about myself. And like everything that you're saying, it hurts me to listen to on such a deep level, and I suspect our listeners will feel the same. It's like, yeah, I don't know what else to say. It's so impactful. I don't know, Nick, what's your reaction?
Yeah, no, it's Paul. It's an amazing story. Thank you for sharing your journey in this, and talk about practicing what you preach. I mean, you really have and do. I guess I'm struck by one thing, which is I imagine many people would have run away as opposed to run towards the thing that gave them this experience. Why do you think it was that that you became a doctor after those experiences in as a 15-year-old?
I think it made me angry that this is how patients were routinely treated, and that it didn't need to be that way, and it shouldn't be that way. because the most traumatic parts of my illness to this day even aren't how sick I potentially was or what the possible outcomes were or where this was headed. It was the day-to-day things. Even at University of Colorado in 2014, I had a bunch of epidurals, right? Epidurals are a great part of what we do in surgery. And one day I was in the bathroom naked. My stoma was bleeding and pooping, and I'm super frustrated with it. And the pain team comes, right? Remember, I'm an anesthesiologist, so these are my colleagues. These are the nurse practitioners and the residents and the medical students. Team of 7 people comes. I'm in a bathroom about the size of a 4x4 box with the nurse with this mess. And the pain team comes in and says, we want to check your epidural. And I said, you know what, could you guys come back later? I'm in the bathroom. I'm almost in tears. This is a mess. I really don't want everyone I know to see me naked in the hospital. And they're like, you know what? It'll just take a minute. We'll just do it now. And all 8 of them filed in this little bathroom with me buck naked, pooping, bleeding, crying. And these are people I know. I'm a tenured professor at this point, right? I've known these people for 15 years, some of them. Thankfully, my wife, who's an ICU PA, walks in and screams at them to get out of the room and read them the riot act and said they could never come back again because I couldn't defend myself. I couldn't make it stop. I couldn't make them go away, and I couldn't believe they're in there. And you know what it made us think? If this is how they treat the people they know, how do they treat the people they don't know? What is happening on a routine basis that some people think this is okay to do to someone they even know really well and should have more respect than that for? They should have more respect for that for everyone, much less someone they know as well as I knew them. I'll never forget it. And it things like that. I feel like I have stories from every hospitalization like that. And those are the traumas that are completely avoidable, completely preventable, but happen every day. And, you know, it's this, when the residents stick the central line 10 times in the neck because they are not getting it. And they don't realize that under the drape, you know, what they see is just a little bit of the neck. What you see as a patient is nothing. And you know, that big old needle's coming right at you. I remember as a 15-year-old, took the GI fellow 45 minutes to try to start my first central line. And I remember saying to him, aren't you really close to my lung, even at age 15? Because he was sticking me for so long. And he finally said, no, we'll come back tomorrow. I'll get someone else to do it. And, you know, I sedate for those things now. I don't want my patients going through that or having to tell me that story. And I don't let my residents do it either. And I always tell them, they complain, oh, that person's so difficult, that patient's a tough patient, or they're crazy. And I always say to them, until you've laid in the bed, I don't want to hear your opinion of the patient. I don't want to hear your opinions about their psyche or how distressed they are, how anxious they are. You lay in there for all night and all day and all night and all day and see how you feel about it. And I'm afraid you're not going to live through it. And I felt to give it meaning, because otherwise I couldn't make sense of any of it. I felt like I needed to do something, because otherwise, why did it happen?
Right.
Like, is it just, I just had bad luck, or was there a greater purpose to it that maybe I could make mean something? Otherwise you go crazy. I would have gone crazy.
Well, your patients are lucky that you're advocating for them based on your own experiences. And, you know, hopefully our listeners can take away some of that too. And just remember, you know, treat your patients with just, you know, recognition of their basic humanity, and do everything you can to prevent suffering. You know, sedation for procedures. Like, I mean, we're good at sedating people. We should use it when we need to.
It's our talent, right? They're not boxes to be checked. And there's this wonderful set of, and it's on my pinned post on Twitter or X or whatever, is this patient manifesto. It's these quotes, and I don't know who wrote them. Actually, I found them one day, and they're so poignant. And one of them is, you know, at the end of the day, you won't remember me ever, but I'll remember your face and your name for the rest of my life. I mean, I can tell you the nurses that were good and bad, the doctors that were good and bad when I was 15, I remember their names. Like, you never forget those things. And I encourage all of you to read those quotes. They're so poignant. One of them is, I'm not used to being naked around people. Please be patient with me.
Right.
When I am in that one, I can't even read when I give lectures without crying a little bit, because it reminds me of some of these events where people just decided it didn't matter that I was a person in there. They just had to check my back.
Paul, my goodness, you know, you've spent on the heels of a ICU admission for your mom. You know, you've come and you've joined us here. You've talked to us about some tremendously important and underrepresented topics in critical care, nutrition, exercise. And I think most importantly, you shared your story as a patient, which to me is something that I truly will never forget as I round with patients and talk to patients. During the course of our discussion, we've talked again about some specifics as related to nutrition. The big thing I took away is oftentimes we need to start earlier than we think. We shouldn't be afraid of using TPN if that's what the patient needs, combining it with enteral nutrition. Using those supplements, making sure protein is dosed just like any other drug appropriately. In addition to those supplements, in addition to just nutrition in general, that was, I think, a big point that I took away from your discussion. We talked quite a bit, I think, about nutrition in the context of CRRT, and many of our critically ill patients are going to be on CRRT, and that's something that I didn't think we were going to get into, but I think is going to be tremendously helpful for for our listeners to chew on. I think, as we sort of transitioned from nutrition, we got into some of that exercise discussion, particularly in the context of that 65-year-old gentleman, and how do we approach this patient? We talked about maybe some pillars of nutrition and of counseling a patient like this, making sure they're appropriately getting protein, they're appropriately getting other nutrients, both macro and micronutrients, testosterone if they need it, and then finally that exercise prescription with a support system as well. I think that's super important. And then finally, of course, the story that you shared us, which I think is going to bring some people, including myself, to tears the more and more I think about it.
Yeah, and reminds us to keep the patient at the center of everything that we're doing, and to, do everything we can to preserve their humanity in the context of illness. They're not, just a carrier for a disease. They're a person. And remember that at all times.
Treat them like you treat your mom. Treat them like you treat your child would be treated. I always think that's how it's great.
Paul, thank you so much for joining us. Where can people follow you on social media? What other websites? Let's plug some things so people who have heard you can hear more of your wisdom.
Definitely. So, as we said, I'm on X or Twitter at Paul_Wischmeyer, Wischmeyer. I'm on Instagram. Instagram is what I'm finding to be the fastest growing way to convey medical information and reach the world. I just went over 100,000 followers yesterday on Instagram. It's a really wonderful visual way to share information. And I'm at Paul_Wischmeyer, MD. So almost the same, just my name with an MD at the end of it.
Thank you so much, Paul. Our listeners should follow you on all those places you just listed. And they should also come to our website where we've got show notes for this. You name dropped many studies. We're going to dutifully try to link to all of those, as we always do, so our listeners can read those studies and find the guidelines and just see those points. So second chance to learn. And with that, we've come to the point where we like to say thanks. Thanks to our guest. This is an amazing episode. You taught us a lot. I learned so much in this episode. Thanks to our listeners. Especially those who leave us reviews and comments, especially 5-star reviews. We really love the ones who give us shout outs on social media, telling us what they liked about an episode or what they want to hear more of. We read all of your words, even if we don't respond, and we really appreciate them. You could follow me at Nick M. Mark on Twitter, and you can follow Cyrus at Askins Razor. You can also follow us on Instagram and Threads at critical_care_time. And you should check out our YouTube channel where you can watch these episodes in addition to just listening to them.
And, I'd also like to make sure we give a big thanks to our sponsor, C-Star Medical. So we're fortunate and grateful that this episode and all the episodes for season 1 have been sponsored by C-Star Medical. They are advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, www.cstarmedical, to learn more.
And before we go, we got to thank our team. So we have our amazing podcast team at PodPaste. We've got Kurt Belknap, who composed our music, and we've got all the other people who are contributing behind the scenes, giving us great questions to ask about, helping us with the outline and the script. So thank you to everybody who contributed to this. Now for disclaimer time, this podcast and all related media, including graphics, videos, text, or property of Critical Care Time, you can share our content freely, but just acknowledge where you got it from.
And the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. One more time, Paul, thank you for your time with us today. We're so grateful. Thanks to our listeners for chiming in, through social media. And of course, thanks to our listeners for listening. I am once again and always will be Dr. Cyrus Nick.
And I'm Dr. Nick Mark. See you all soon.